integration of oral health into pediatric medical care concepts and preventive strategies. Butte, Glenn, and Tehama County's local oral health programs are excited and truly appreciate you taking your time to join us today. This webinar is a result of a wonderful regional partnership between the three counties. In September of 2019, Butte County reached out to Glenn and Tehama to inquire about joining together to plan an in-person summit on integrating oral health into medical practices. The collaboration makes total sense because all three rural areas encounter very similar barriers and problems regarding access to oral health care for children. We had planned on a spring of 2020 summit, and then COVID-19 hit. And just like everyone else, our plans were put on hold. So our challenge was to regroup, to review, and to synthesize the avenues open to us and decide how to go forward. We chose to pivot and then plan a virtual event. We were incredibly fortunate to secure Dr. Bahar Ahmadzada as our speaker. Three counties have met with Dr. Ahmadzada for the past 8 months to plan this informative event. She's an amazing advocate, an innovation consultant, and has facilitated the discussions with us, not only us, but with managed care organizations, which in our counties is Anthem Blue Cross and California Health and Wellness. Children's Health and Disability Prevention Program, CHDP, and others. Throughout this process, we've benefited immensely from doctors' knowledge, insight, and sense of humor. Today's webinar will present best practices in integration of oral health and the practical ways in which primary care providers can bring in preventive oral health assessment, education, and care, including fluoride varnish, application, and referral to very young children, especially for children under 6 years of age. We will also look at the ways that we can support children's oral health as a continuum from pregnancy to adulthood. Next slide. Welcome and introductions. It's my great pleasure to introduce the members of the team who worked hard on planning and bringing to fruition this webinar today. Susie Sapin is the Butte County Local Oral Health Program Coordinator. She is the person who initiated this wonderful collaboration. She's worked hard to keep things on track and keep us on track, and is utilizing her technical skills to facilitate this event today. Julissa Ramirez is the Glenn County Public Health Tobacco Education Program Coordinator. With her design skills, she created the flyer, she's developed pamphlets, and has provided valuable assistance in developing this webinar. Angela Martin works as the supervisor for Butte County Public Health's Oral Health Program. She has over 16 years experience working in the public health field as an educator in the rural North State. Andrea Shulkin is a registered nurse and our champion. She has extensive experience in pediatric nursing and is a certified pediatric nurse. Andrea is our champion, and in her current position as a nurse manager at Northern Valley Indian Health Children's Health Center in Chico, she will share her skills and her insights on how they integrate oral health assessments and fluoride varnish into NVIH's scheduled appointments with youth. Dr. Bahar Ahmadzada is our today's guest speaker. She's a dental public health and innovation consultant, an adjunct faculty at UCSF School of Dentistry, and a member of the California Health Advisory Group. Her work at the local, state, and national level has focused on the integration of oral health into pediatric primary care, prenatal care, and homeless programs, community-based oral health program planning, including school-based and care coordination programs, as well as policy development and evaluation. She has served as the Alameda County Dental Director, in which role she established Healthy Teeth, Healthy Communities, program to create a countywide coordinated dental care at different levels of care. Her motto is innovation and collaboration. Next slide, please. So I'm going to go over the outline and the objectives. So today we're going to be having presentations, doing questions and answer. We're going to have group discussions. So this, we hope, is going to be a 3-hour actively engaged webinar. We want to acknowledge the collaboration with CHDP and managed care organizations, which in our communities are Anthem Blue Cross and California Health and Wellness. So our objectives: we want to learn about the importance of oral health in early years and effective preventive strategies. We're going to describe ways of integrating oral health in pediatric medical care. We're going to incorporate oral health screening and fluoride varnish application into the primary care practice. Work among local systems to refer a child to a dental provider, and create strategies to support oral health during these COVID-19 times. Next, please. We want to give our disclaimer. None of us have any financial relationship with any commercial interest related to the content of this presentation. Just a few housekeeping tips. So we are going to be recording the webinar. Please, if you have questions, if you can put it in the Q&A box, we would appreciate it. So the CEs and CMEs information. So you're going to be filling out an evaluation at the end of the webinar. And if you please specify whether you require CEs or CMEs, that would be appreciated. More information will be emailed to you later. Next slide, please. I would like to share a little bit about Tehama County. So Tehama County is a rural area. Our population is approximately 65, a little over 65,000. So when you look at it, it's a wide open rural area. We are located midway between Sacramento and the Oregon border, and we're situated in the northern Sacramento Valley. We have I-5 going through the county and the Sacramento River. So when you look at it, we're going from the majestic heights of the snowy Southern Cascades and the Sierras over to our east. You tumble down to the Buttes and to the rolling hills, and then you continue down to the Sacramento Valley and the river. And then we climb back up in elevation on the coastal range in the west. So there's a lot of incredible topographic diversity in the county. That always also can bring challenges for us. We have 3 areas, unincorporated cities in the county: Corning and Red Bluff and Tehama. Corning and Red Bluff are right on I-5, and that's where the vast majority of our medical and dental services are located. So when we look at some of the barriers for our children accessing and adults accessing care, we identify we're a federally designated dental health professional shortage area in both geography and low income population. And it's been that way for over 20 years. We just don't have enough dental providers. Financially, poverty is an issue. Our median household income is a little over $44,000. We have almost 26,000 medical eligibles. So transportation is an issue. I was talking about how we go up into the mountains, we come to the valley floor, and then we go back up into the mountains. So if you're up in the mountains to get down to the valley floor, that's probably about an hour's drive. And if you think about it in the wintertime when it's snowy, that makes it more difficult. We do not have any water fluoridation. And we have a lack of educational programs in the schools on oral health. Our bright and shining point, though, is we have the Tehama County Public Health Advisory Board Dental Committee. They've worked diligently over the years to promote improving oral health visibility and understanding, and its importance in the community and why it's important. And the members' advocacy has helped immensely in bringing awareness to the issue. So now I'm going to change over to Julissa Ramirez, and she's going to talk about Glenn County. Thank you.
Hi everyone, my name is Julissa Ramirez. I am the former health educator for the oral health program in Glenn County. And Glenn County is very unique. It is the smallest of the 3 counties that are described today. We have a very small population of about 28,000 people, and it does range up to 1,327 square miles. We are also nestled in the Sacramento Valley. So we are south of Tehama County and then also west of Butte County. And in Glenn County, we have 2 unincorporated cities, Orland and Willows. And we are also home to the Grindstone Rancheria, which is the reservation of the Grindstone Indian Wintun Walakai Indians. And some of the largest barriers, very similar to Tehama County, is we have very, very limited transportation. We have lack of fluoride, water fluoridation, and there are only a few medical and dental providers in the area, and many of which do not accept Medi-Cal and Deni-Cal. So many of our constituents are left to travel out of county to seek services. And, Tehama and Butte already have a limited providers. And so a lot of our folks are going to them as well. So very, very impacted. The oral health program does have a thriving community coalition that is passionate about educating the community on the importance of oral health care. And they have helped the local oral health program reach school-aged children tremendously. Their mission is to build healthy futures one smile at a time, and they have a vision of removing barriers to maintain optimal oral health. In addition, the local oral health program works very, very closely with the tobacco education program and also the WIC programs to ensure we are reaching, our adult populations that are, former and current smoker and vapors, and then also our pregnant and breastfeeding mothers. And now I will turn it over to Susie with Butte County.
Good afternoon, everyone. My name is Susie Sapon. I'm with the Butte County Local Oral Health Program. And just to give a background on our county, our population in 2017 was 229,000 for the county. Our median household income was about 48,500. We have 5 incorporated communities. You can see those there: Chico, Paradise, Orville, Biggs, and Gridley. Our southern part of the county, our county line, is just about a little over an hour drive from Sacramento. Chico is our most populous city at 88,000 people, and Biggs is our smallest at just about 1,800. Our population breakdown is almost 73% identified as white, 15% identified as Hispanic, 4% Asian, 4% identified as 2 or more races, 1% Black or African American, and less than 1% identified as American Indian, Alaskan Native, Native Hawaiian, or other. Next slide, please. So for those of you who are not familiar with our local oral health programs, our program started in 2018, and that was a result of Prop 56 passing in 2016, and that allowed the state to increase their taxes on tobacco products. So with that funding, our local health program started, and we were able to collect oral health data, which we desperately needed because a lot of our counties didn't have a lot of data to begin with. We were able to complete a needs assessment and then also a community health improvement plan based on that assessment. We were also able to build coalitions to engage community agencies to help us in our efforts to improve oral health. And then since we're talking about integration, one of the activities that we here in Butte County have done is work closely with our local CHDP program and their medical providers in that program. So we were able to give the providers and their patients toothbrush kits that came with, toothbrushes with bright colors and fun shapes, stickers, books, activity books, and brushing calendars, things like that, that would really entice young children to want to brush their teeth and to get healthy oral habits started. And then this webinar, we hope, is just the start of many more to come. We do hope we have more webinars in the future to help us continue to support medical providers and others in the community and their continuing education on oral health. So with that, I will turn it over to our main speaker for today, Dr. Amanzadeh.
Thank you so much, Susie and Mary and everyone. It's my pleasure to be here today. It's an honor to have worked with these amazing 3 counties and their local oral health programs. And it's just such an honor to talk about this topic, which I really care about, integration of oral health into pediatric medical care. And what are some concepts and what are some preventive strategies around that? So as Mary mentioned, our objectives today, I'm not going to repeat them, but I'm really hoping that by the end of this 2.5, 3 hours that we spent together, you really get a good sense of why is it important and what are some strategies that are practical and usable in medical offices to integrate oral health. And also, what are some innovations, like what can be a start with in these times? So with that, let's get us started to get to know each other. So we're going to start with a poll. If you could bring us our poll, Susie. I'll start with myself. Oh, here's the poll. So go for it. And then I'll introduce myself. So if you are a pediatrician, if you're a nurse practitioner, or if you know other pediatric medical staff, dental professionals, public health professionals, you're from local oral health programs, you're from managed care organizations or other. Fantastic. Seems like we have a diverse group. Okay, good. Shall we end the poll now? Almost there. 10 more people. Okay. From 39 people, here we are. We have pediatricians, nurse practitioners and nurses, dental professionals. Yeah, we have a very diverse group, public health professionals, local oral health program, and we have representatives from managed care organizations on the call as well. Fantastic. Thank you so much. So I am, as Mary said, I'm Bahar Amanzadeh. I'm a dental public health consultant, but I come from a background of being a clinician and then being in public health in academia at UCSF, and also being the dental director at Alameda County Department of Public Health. So here I am hoping I can share my experiences with you all around that. Okay, so let's delve in. Why children's oral health matters. I'm sure a lot of you have had an experience of that, even through your own personal life or from seeing the patients. But really, you know, when we look at the big picture, children's oral health really affects their development and well-being. There are many studies that show that the children who were not able to get appropriate weight and height, and they have active, untreated dental caries, when that was taken care of, then they were able to get that. So very, talking about development, right, child development. And when we talk about quality of life, chewing and eating, smiling, self-esteem, there are many studies that also look at that, right, like around with teenagers and self-esteem, that how it affects one's self-esteem, their appearance and their health of their teeth. When it comes to very young and also elementary school, there's studies around the school performance at how lack of optimal oral health affects the school performance. And also, when we're talking about primary teeth, that affects the trajectory of permanent teeth and adult oral health. So it's not just, oh, these are, baby teeth and they're gonna fall off and we're gonna get a new set of teeth, right? Which you might hear from some of our community members and some of the parents, but we know that that's not the case, that there's a continuum. And there are cases that untreated tooth decay has led to life-threatening systemic infections, to disability, and to death. So these are all, we're talking about a preventive disease here, right? So, and that's why we're talking right now at why can we, how can we shift our focus more to our prevention so that we don't have to experience all of these in our most vulnerable children. This is my daughter when she was less than 2 years old. She's a teenager now. She doesn't have any cavities, but she had a dentist, public health mom, which you know, for a lot of our community, that's not the case, and that's why we're here to see how can we bring modalities to our communities. Just a little bit more around that. The impact of poor oral health is economical, it's emotional, it's social, right? It gets transmitted. We're going to talk a little more around the etiology later. It gets transmitted from pregnant women and from moms to their babies. So lost work hours, reduced chance of employment, increased comorbidities for elders with other diseases. So again, I just want to kind of frame it that this is not like, okay, teeth and then the rest of the health that are separate from that. Just a little bit around why do I care personally? So here is a case of Jose. These are the x-rays. For those of you who are not in dental field, you see the teeth here, and then the cavities or these areas, this kind of like radiolucent kind of black areas that kind of like go into enamel of the tooth and then go into the root of the tooth here, right? At the pulp, basically. When a cavity, when a caries has become cavitated, right, gets all the way to the pulp, like here, I don't know if you see my pointer or not, when it gets down to here, that means that it has gone to the kind of live part of the tooth, to the nerves, to the arteries over there, as an infection has gone to the bloodstream, basically, right? So in this case, this is a case that came to me, and we had a program that's, you know, we're authorizing treatments for uninsured kids. Jose didn't have any insurance. His parents have been immigrant in this country since he was 1 year old, and he's 5 years old, right? So he hasn't seen any dentist, but he has been seen by a primary care provider at least 4 times, right? At least, right? We know more than that, right? And these active infection, 5 active abscesses, and these, I can't actually remember exactly, but it was around 16 or 17 active decay that were to the pulp, right? Active infections. So you can imagine this child being in pain, not being able to chew, not being able to smile, not being able to focus, right? And the parents not knowing what's going on, basically. So this child, again, this child has been gone through the system, like primary care. I mean, we can talk about lack of dental access. That's another issue too, but how can we catch this before it gets to this place, right? And that's why personally I care about this subject. Like, how can we, as a medical and dental profession, together catch this so it doesn't get there? We talked about this, but just wanted to make sure you have that. Really, poor oral health impacts the school achievement, right? So if a child doesn't go to school, what happens? Basically, the school loses money, right? And then the child loses education. And that's kind of like a vicious cycle of poverty, oral health disease, and low academic achievement that we want to get out of it, right? And when it comes to oral health and systemic health, they are much more connected than we have been taught in our medical schools and our dental schools, right? We have been like, here, the rest of the body, here's the teeth for dentists, and whereas really in reality, much more interconnected, right? And this is like just a view of some of that interconnection. For example, when you talk about diabetes, right, in adults, periodontal health is directly correlated with diabetes treatment success, right? So there are cases that diabetes was not under control, and the periodontal health got under control, and then diabetes was able to be controlled as well. Periodontal health especially, and by periodontal health, I mean the health of the gums, affects cardiovascular disease and respiratory disease. And there are connections around the strokes, dementia, end-stage renal disease, atrial fibrillation, and many more, that oral health has affected systemic health. There are many studies around the process of inflammation and how that process of inflammation is a process that is connected to many other inflammatory diseases in the body and can trigger that in the body, including arthritis as one of those. And also, we know there are many systemic health issues that affect oral health, right? Nutrition comes on the top of both of these. And the fact is that if you don't have teeth that you can chew the food, right, you're not going to be able to digest that, and that affects your systemic health, right? And the other way around, if there are if you're not if you're eating sugary food or, food that are low in nutrients, right, that also affects your oral health, right? So kind of like it all goes together. Many medications or dry mouth and all of that are systemic diseases that affect oral health. People with disability, many disabilities have affect the bodily functions or affect oral health through the medications that the person takes or through lack of access to care. Tobacco use, another area. So I'm not going to go into details, but there are many research around that how this is a cycle that goes on, and we need to really break that. So if I don't talk about social determinants of health, then I'm not a public health representative here, right? So oral health and social determinants of health are really affecting each other. They're really tied to each other. And what I mean by that is that when you look at a child oral health, and this is a model published by Dr. Susan Fisher Owens and one of our amazing colleagues at UCSF, a pediatrician who has done a lot of work around this. So when you look at this social ecological model for children's oral health, it's really a child's oral health, and the areas that affect the child oral health is embedded within family level influences, and that's embedded within community level influences. Some examples, and feel free to put in the chat of what are some thoughts that you have. What are some community level influences? I know Mary was talking about community water fluoridation, right? These are community level influences that affects all of that. What are some family level influences? Families' access to oral health, right? Or culture, or family practices, right? So yeah, feel free to put some stuff in the chat. I'm going to check to see baby bottle use, right? These are like some family level influences, family overall diet, right? What are some routines in the family around toothbrushing, right? So these are again some kind of like a high level influences that affects the child oral health. When it comes to the child level, like the child's microflora and development of the child affects the child oral health, but that's really not the main thing, right? And in most of the cases, you're right, genetics exactly affects the child oral health, and that's part of that, right? And when it comes to the family level influences, culture, family function, family support, right? Like if I'm a mom that I have to go through 2-3 jobs, right? And I'm not there to, make sure that my child is brushing their teeth or what are they snacking on, right? Then that's a family level, or maybe it's systemic level influence that affects that child's oral health, right? So when we are talking about that and working with families, like having that lens, this will help us as providers to be less judgmental and also being able to have that wider view. Also adopting a health equity lens, and how, when we're talking about disparities, how is that affecting a family unit and a child's oral health? Here's another point that I want to make. Throughout the presentation, you'll hear me talk about that. But when we talk about prenatal oral health and how it affects early childhood oral health, and then how that, primary teeth, health of primary teeth affects the health of the permanent teeth, right? And then the teenage years oral health, and young adulthood and adulthood, and then how, kind of like it's a cycle, right? And then older adulthood, and how, an older adult might lose their teeth sooner because of, how their early childhood actually oral health, right? So kind of like looking at these as a continuum, and kind of like being able to support that as a continuum. All right, so we are in the time of a pandemic. This is a very, to say the least, this is a challenging time for a lot of us, for our communities. And when it comes to our communities in the rural areas, their access to cares have already been huge, and that has added to that, right? So, and this is not only access to dental care, this is access to care in general, getting the social support, the impact of poverty, all of that, right? And again, oral health is part of that continuum. So just like thinking about that, and thinking about, here's what we know is the impact of oral of COVID times, of pandemic on oral health. And then, toward the end of our presentation, we'll talk about some innovations around that. And feel free to put in chat if you have had any observations around that. From my observation, talking to my colleagues who are clinicians, really less people are coming to dentists for preventive care, right? And less children are coming to preventive care, right? So what happens as a result is that, we're going to have more serious oral health issues, just developing underneath without us seeing it right now, right? And there are other concerns for the families, such as economical and health concerns that are going on. And like any times of hardships, most vulnerable population gets affected the most, right? So we really need to think innovatively about, when we have an access to a family, how can we look at the whole person? How can we integrate oral health into that? Okay. So this was just a background to get us started. And now I'm gonna go through some data here, right? So if you need to get your tea, your coffee, I know the data discussion for some people, I'm like that, I get excited and I just like adrenaline rush. But for some people, it gets a little boring. I try to not make it as boring, but it's still just giving you a little warning. Okay, very actually interesting data. So some of this slide has been borrowed from California Office of Oral Health from their project director meetings a few months ago. So when you look at this data, for national data, you can see the disparities among these different races, right? This is for children ages 2 to 19 years old. And you can see that Hispanic children have the higher rate of total dental caries, right? Compared to non-Hispanic white, right? Like 57% to 40%. And then after that is non-Hispanic Black, and then non-Hispanic Asian, right? After the Hispanic population. And when you look at untreated dental caries, right? So you want to say what's dental, and what I mean by dental caries is basically cavities, right? It's another terminology for that. When you talk about untreated dental caries, that's another part, because a child could have had dental caries and then it has been treated. It's just still, the bacterial is still going to be high. So that child is still high risk, right? But when it doesn't get treated, that tells you that there's, on top of that, access to care issues, right? So as you see, there are also disparities around untreated dental caries, and that is the highest around non-Hispanic Black, and then after that Hispanic, and then non-Hispanic Asians. actually one Hispanic white and then non-Hispanic Asians. So it's an interesting data to look at this disparity. And you look at California and what has happened in California from the 2004-2005 data and then to this recent data that has been collected by Office of Oral Health in the state. You will see that, you know, there has been some improvements, and that's amazing. And I think a part of that is really appreciating the work that all of you are doing at the community level, and kind of like with interventions, with the trainings, with bringing that to different levels of the community and provider level work. So untreated dental decay is getting less, and caries experience becoming less too. What we don't see here is disparities, right? Disparities both geographically and disparities both among different populations, which again, that's why now we're talking, right? Because we know in rural areas, there's a big disparities around that. So just a little more information around these counties, around the demographic of children in these 3 counties. Butte County, when you look at, it's mostly 63% white, and after that, Latino populations, right? Poverty is 44%, so high level of poverty. Tehama County, 60% level of poverty, so it's higher. The percentage of the Latino population is higher as well, right? Still 55% white, but 39% Latino. So it's a little more diverse, Tehama County. Glenn County is a smaller among these 3 counties. And as you see, Latinos are the highest percentage of the children, right? So the demographics changes a little bit in Tehama County, in Glenn County. Poverty is 53%. Again, like all these 3 counties have a high level of poverty. And again, with just having that rural classification just gives you more background as far as the overall living condition. Water fluoridation, as you know, community water fluoridation is one of those public health infrastructures that helps a community to be able to receive the benefit of better oral health as an infrastructure, right? And in a lot of the small counties and rural counties, that doesn't exist, right? So Butte County has it in two cities, in city of Gridley and in Oroville. Whereas Glenn and Tehama County are not for it at all, right? And the rest of Butte County is not for it as well. So this is something that we have to keep in mind as we talk about advocacy, but also what can we do to overcome this when we are working with our population. This is an interesting data. So when we look at the receipt of dental visit during pregnancy, it's important for us, even when we're talking about children's oral health, because as we talked briefly, a mom's oral health affects the child's oral health, right? So, and there are different mechanisms and different studies are coming out that how that happens. Part of that happens as part of the bacterial transmission between mom and a child, but there are also other ways that this is happening. So when you look at we have only Butte County as part of this data, and it's below the average, California average. And it's important to look at some of the counties that are higher achieving here, such as Sonoma and Marin when it comes to prenatal health. And what is happening there, right? So big disparities in our counties when it comes to that, from 73% to 22.7%. And this is another point of data that is really related to when we talk about integration of oral health into medical practices. Preventive dental visits for young children 1 to 2 years old. As you know, as we talked, we're talking about access to care, not having enough dental providers who accept Medi-Cal, especially in the rural areas, right? So when you talk about 1 to 2 years old, if they're not dentists who can already meet the need of the older children or adults, then there's going to be less of them that are going to actually want to see you 1 to 2 years old, right? And kind of do preventive visits. And basically, there are just not enough providers to do that, right? And maybe not enough also knowledge to do that, right? So if you look at that, and you look at Glenn County here at 30%, Tehama as 27%, and Butte at 20%. So Butte is the lowest. California average is 23%, but again, this is not the goal. 23% is not the goal. 23% is the average because this is so low, right? A lot of the counties are low in that. And this is around 3 to 5 years old, right? So the same here, California average is around 50. Glenn County is doing a little better compared to the California average and to the higher performing counties. Tehama 52, and then Butte 45. So as you see, again, that is a little better than 1 to 2 years old. But again, by 3 years old, 3 to 5, if that child hasn't received any preventive dental visits, it's already too late to prevent. I mean, it's better than nothing, right? But it's, we want to catch them earlier. Just a little more kind of like around some other data that are very interesting about these 3 counties. Around like 45% of the children are in 45% of children in foster care has got tummy dental exam in Tehama County. In Glenn and Butte, that's higher, 79 and 69, but that's an area for Tehama County to work on. When it comes to visiting the dentist in general, right? And this is children now data. You would see there are more of them around 40%, right? So we really hope to improve that from 40%, right? And okay, we talked about the need, right? And some of the medical utilization. And now look at our medical dental providers in the area. So we were lucky as part of these collaborations that we're able to work with our GIS teams in these counties. And that's what collaboration and teamwork does, right? You start kind of looking deeply into stuff. So here is Chico, right? Here's the city of Chico, and you'll look at this, and not bad, right? You have different, 1, 2, 3, 4, 5, 6, 7, 8, 9. There are different entities. We're going to have the index in a second, but you look at that saying, okay, if the rest of the county is like that too, maybe we're good. And then you look at that. That's the only place in those 3 counties that has that concentration of medical dental providers, right? And Red Bluff has some of the rural Indian health services as well as one. Most of them are Indian health services actually around Red Bluff. And then there's some here around Oroville. I think that's Oroville. There are a few more providers. But when you look at this map, and it's very interesting because this is median household income. So when you look at median household income, the greenish that it gets, it shows you that the lower the income, right? So here around Chico, the income is a little higher, right? Again, it's around 58,000. It's around 49 to 58, right? We don't have any dark purple anywhere here, right? And then as you get to some of these areas in north of Red Bluff area, that is really low, right? Is 35,000 or less as far as the median household income. So some of these areas, as you look at, and we're going to look in the next map, some of these areas actually have high population and low income rate and no dentist, right? So it kind of like puts all of these in layers of need as well as lower level of the basically access to care. So look at this one. This one's also very interesting because when you look at this one is families with children age under 18, right? So, one might think, oh, it's a rural area. So, maybe there are not many families who are living in this, that area, but it's not always the case, right? So, and also, we want to look at it from the lens of equity, right? even if it's a low population, those people who live there, right, the access to care barriers, it's much more higher, right? So how do we actually work at that from the health equity lens? Here, you know, this is just an example when we're looking at the north of Red Bluff, right? High poverty area, you know, family, you know, actually high population. You know, it's like a blue, like, you know, under 664. And you know, not much. I know it's Red Bluff down there, but not much around on those areas. So the same thing if you look at around like these big areas, rural areas, and no providers. All right, so here is another map that kind of we did through Tehama County. Mary actually created this map herself, and really looking at the population of medical eligible, and you know, what are some of the dental clinics around there, right? Some of the medical providers, basically, right? So again, kind of like here, north of Tehama County is one of the high population areas. So as you can see, there is lack of providers, basically. And also when you look at the numbers and the number of providers, right? Like 11,000 around this area of Red Bluff, and we only have three dental clinics for the whole area then. Okay, so we saw the extent of really the lack of access, right, through these maps, right? And now, you know, we're talking about oral health integration, right? And we want to, I'm really making a case, and I'm a big believer of this case, and that's why I'm making the case that if we integrate oral health into our primary care as a preventive measure through what we're doing, then we can overcome some of those access to care barriers for our children, right? So, and this is some data that just came out 3 months ago, and this looks into filed varnish application by managed care providers, right? And again, we are talking among systems and how we can bring our systems together, and that's why we're looking at that data too. And the rates are low, right? When you look at that, the rates are really low. So these 3 counties here, I mean, now I can recognize up here, you know, some of them are a little better, but in general, like it's around 5 to 12%, right? And in one of these, it's one of these counties, I think it's Butte County, no, it's Glenn County, is actually below 5%, right? So basically what it means, like below 5% of the managed care providers have provided fluoride varnish to children. And when you look at the, you know, and these are some aggregate rates, and you look at the some of the disparities, American Indian Alaskan Natives have got the less. Black and African Americans and Native Hawaiian and other Pacific Islanders have been the populations who have received the less, right? So again, disparities, right? So kind of like keeping that in mind. And when you look at like urban areas, they're doing a little better, right? But as you go more toward the north of California, toward the rural areas, that gets less and less. And just wanted to just, again, kind of wrap it up. And, you know, I have reviewed the great needs assessment that these 3 counties have done through establishing their local oral health programs and in the last few years. And some of the main barriers that you see that it's kind of repeats itself in all of those needs assessments, you know, is the most vulnerable population has the highest risk and rate and severity of the disease, and the hardest barriers in accessing the dental care, right? And rural areas, low access to care is multiplied by geographic barriers and lack of local providers, and also poverty, right? And poverty is a big area in that. So cost, not finding a dentist, not knowing the importance of not having the kind of like a health literacy or educational backgrounds, educational programmings in that areas, lack of transportation, language barriers, lack of fluoridated water, right? So all of these makes this even more important for us to have this discussion today. Good, okay. So I'm hoping that you had your tea and your coffee and you're not so bored. We are here together for 2.5, 3 hours. So let's do a poll. Let's see what part of this was interesting for you. Did you know that this is that prevalent? Did you know that oral health is this prevalent among children? Again, for some of you, you might know, and some of you might be just like, I had no idea. So let's look at that. Okay, maybe we have a plateau, right? So 66% of you knew, and 29% knew to some extent, but not to this extent, and 6% not at all. So thank you for this. So, and I'm happy that we're able to share this, and again, that's where this starts, right? That's where any initiative starts. Okay, curiosity and understanding what's going on. All right, so with that, I'm going to delve into how to do this, right? So, we know that is important. And now I want to say, actually, we're going to talk a little more about why it matters. And then we're going to go into how it matters, right? A bit of the history here for you. And it's not like just 2 or 3 more slides, right? So Surgeon General report in 2000 aimed to increase public awareness around early childhood caries, right? Which is basically the severe caries in early childhood years, right? So, and since then, people, looked at the data. Healthy People 2010 had a goal of reducing it by 11%. Unfortunately, it was increased by 33%, right? And then, since then, again, it hasn't changed much, right? So in the last 2 decades, it has relatively stayed the same. And California is amongst the low 10 states in providing dental care to children enrolled in Medicaid. And there was a study by Pew Foundation, and there was an audit of the state medical program. We're kind of looking into, that was I think 2014, kind of looking into what's going on. How can we really make our medical dental program more user-friendly, have more provider, what's going on, right? And one of the main findings in those data was that there's enough number, but when you look at the distribution of dental providers, especially in rural areas, that's really not equally distributed, right? That was one of actually main findings, and many more about how to revive this program, right? And again, kind of parallel to that, right? Okay, we want to have more dental providers, but parallel to that, there are many public agencies, including American Academy of Pediatric Dentistry, American Academy of Pediatrics, and USB SDF, that have really urged primary care providers to incorporate oral health assessment and preventive strategies into well-child visits, right? Because when you know that exists, it's like that's part of the overall health. So how can we work together as a team, right? So just a little bit of like a history over here for you. And then there's opportunities in that, right? Patients come to see their medical providers much more often, right? 90% of infants up to age 1, they see primary care providers, where only 2% see a dentist, right? So, and that's where actually the prevention starts, right? We talk more, you will get to understand that more deeply, right? And then, as healthcare providers, as we work together and we build capacity and awareness and leadership in our providers among this epidemic that it's kind of like hidden, right? So that's part of like building leadership in our medical providers population. And, well-child visits is really an opportunity to do that, right? I would like to hear more from you in the chat. What are your thoughts? Again, we're talking about that, but what are your thoughts of some of the areas that we could, as primary care providers, you would like to, or if you're public health professionals or dental professionals, you would like to see this happening more, right? What role can they play? What role can you play, right, in your county? So just, keep it coming in the chat as we move forward. some of the big picture outcomes is that when we do that, prevention, early detection of oral disease, right? So again, it's preventable. Increase access to oral health, because as part of that, the families get aware and then the referral happens. Reduce oral health disparities, right? And social and reducing social and economic costs, right? So when we are talking about, again, the cost of treatment versus the cost of prevention, right? That's a huge difference, right? In many cases in early childhood caries, it's at least 10 times difference, right, between those two in some of the studies. And then that's economic cost, but when you talk about the social cost, the health cost, right? If any of you have heard the stories of the children who have gone under general anesthesia, right? And the emotional cost of it for the families, right? Or the children who have unfortunately experienced death and disability because they were not able to receive dental care on time, right? So again, we don't always hear those stories, but kind of looking at that social economic cost, here's what the bigger impact that we're talking about. Thank you for the chat. Yes, that somebody is mentioning that they have a sister dental clinic, right? Maybe they can be trained to make appointments for the kids in dental during primary care visits. Yes, thank you so much for that. That's really interesting that when we talk about integration, sometimes we think about, oh, this is like this little practice in the middle of nowhere. They don't have any dental clinics, so maybe they need to incorporate, oral health. The fact is, sometimes within the same organization, the integration between the primary care and dental doesn't happen, right? And that's why we need to think about our systems, right? How to kind of train both sides to do that referral and to work that together. And very good point about clinic administrations here, how to make it a priority. That's exactly where it starts. It starts from the clinic administrations to understand that this is part of the general health, right? And if you don't want to treat urgent, that's a very good one. If you don't want to treat urgent care, how can you start from prevention, right? Very good point. We must treat medical patients in a medical system, not dental patients that self-identify by the presence of pain. Yes. Very good point. Yes. I'm seeing people talking about ladders here, Los Angeles Dental Registry, and that's a very good point. And I know state has some priorities around that how to make that referral a little more kind of embedded in our systems. Thank you all for these points. Please keep them coming, and I will look at them throughout. So let's look into some of the strategies here, right? So we know that we need to work in our system, right? And that's a big piece of it. And, with the information that we have, how can we start where we are, right? Okay, this is the fun part. Keep the teas and coffees and food coming, but this is the fun part. So let's talk about the definition and etiology, right? So caries destroy tooth structure. And what happens is that leads to infection, pain, and loss of chewing function, right? And when we talk about early childhood caries, it's basically an aggressive form of dental caries in this age group, 0 to 71 months. The beginning, when early childhood caries was identified, it was more called nursing caries or baby bottle tooth decay. And then later, they looked at the etiology is wider than that. Nursing baby bottle is one of the areas. Apologies just for a second. Yes, yeah, and as I was looking, and I was looking into the chat too, people kind of really putting into some of the cases that they see, right, that they come for pulpotomies and crowns, right, and how that should have been prevented from there, right? A 19-month-old patient that has needed that, right? And pulpotomy, for your information, is kind of like really, it's kind of baby root canal, basically, right? And when you look at this early childhood caries, when baby bottle tooth decay, it's really influenced by socioeconomical status, right? It's also influenced by feeding habits, early access to dental care. I know we have beaten that horse already. Fluoride exposure and family caries experience, right? So when we look at the risk and risk assessment and why it matters, we kind of look at that and say, why is it important to identify that early, right? And I think with the, as I'm hearing and I'm looking into the chats and how people are kind of like, there's some level of frustration, right, from dental providers that we see that, like a 2-year-old that comes to me with this level of hair. How can we kind of work within our system, right? How can we do that, right? To kind of bring the medical and dental levels together, right, to succeed. That's a very good point. Prevalence of early childhood caries. That's okay. If you haven't heard this, you have to put that in the chat. Did you know that it's the most common chronic disease in children? 5 times more common than asthma. So when I talk to my medical colleagues, to my, my nurse practitioners and nurses and pediatricians colleagues, when I talk to them and I say that, they would say, really? Like 5 times more common than asthma? And still that's not part of what we include into our flow of what we do. So again, I want to hear from you. If you haven't heard that, kind of like, either raise your hand or put in the chat. It's sometimes some people just like, we have no idea. And 30 to 50% of low-income children have ACC, right? So basically 80% of disease happens in 20%, right? And the disparities that we talked about, right? Influenced by ethnicity and social economic status. It's a public health crisis. And I'm just putting some data here that is related to us and the demographic of these counties we're talking about. 70% of Native American children may have ACC. Native American population is among the populations who has experienced ACC to the greatest level in our nation. So that's something to have in mind as we're working with this population, right? And then when there is untreated in primary care, right, in primary teeth, that's even, as we talked about, that kind of brings more level of pain and infection, right? And in Hispanics is 2 times. In Hispanic population, the untreated caries is 2 times than non-Hispanic whites. I correct myself, in Hispanic and non-Hispanic Black is 2 times than non-Hispanic whites, right? And again, many cases of them are undiagnosed, right? Because you may not seek, as a parent, you may not seek in early ages, you may not seek dental care, right? So that's why it goes undiagnosed. Okay, so get ready. We're gonna show you some pictures of teeth. And if you haven't been been exposed to that and haven't seen that, it might be new to you, right? But that's how we learn about it, right? Just looking at teeth. So, and at different stages of health and pathology. So we'll have a slide that look at the healthy teeth, but none of these are healthy, basically. The first one is white spots. Basically, you see these white spots on the gum line, right? That's the start of the disease. However, the good news is that this is reversible. When we put all of our effort to that stage, right, and we catch it, and then we put all of the preventive strategies for it, varnish, modifications in the diet, oral hygiene, right, then that's reversible. It's amazing when you see that happening, right? If it doesn't happen, then it will continue the process of decay, because this is demineralization at the beginning, right? And then it will happen, and then cavitation will happen, right? Basically, more of that is going to go away. And then after that, you will get the severe aspect, right? So we'll talk about a little more about the process of decay in a little bit, so you will see that. Progress of ECC, when you look at the progress of this disease, right? really, when it kind of like goes fast in the children who are high risk, right? And that's why you want to kind of like really do the assessments, often as you see that, right? It's very rapid, it usually starts from the upper front teeth, and they're usually the ones that are affected, and then it moves to the back teeth. And within few months, you see this going like this, right? In this case, you can actually see it's probably like a little abscess up here in the upper left of the patient here, in the vestibule here, right? So if you kind of like, when you're doing the assessment, you kind of like go up and you look at the teeth and see what's going on, right? So kind of just like keep that in mind, that this is a very tricky disease, the way it moves fast. When you look at the caries, dental caries as a process, it really is a multi-step process. And let's call it what it is. It's an infectious bacterial disease, right? Infectious bacterial disease. So let's make that sink in for all of us, right? Because then we know that we need to actually deal with the infection, right? So here is what happens. Here's a bacteria, right, in the mouth. We'll talk about what kind of bacteria in a second. Here's sugars in general, right, and what they are. And here's a bacteria that basically eats up that sugar, produces acid. Acid demineralizes the tooth structure, right? And if the demineralization keeps happening and there's no demineralization happening, then that's when you get caries, right? So here, just make sure you see the whole picture here. So basically, what happens is that after the bacteria, which including a streptococcus mutans and lactobacilli, they're one of the main ones, but there are more than like 50 bacteria in the plaque. And what plaque is, I remember I was in dental school, and one of our professors, perio professor, wanted to show us what the plaque is. I don't recommend that, but he kind of like went around his gum line with his kind of nails, and then did that. Like, you see this white? This is plaque. I didn't brush today. So this is basically where, that's the plaque, and it's full of bacteria and remaining of the food, right? And then what happens is that the bacteria gets transferred in two ways: through vertical transmission from the mom to the child, and horizontal transmission among siblings and other caretakers, right? And the oral bacteria in the mouth produces acid, right? It stays for 20 to 40 minutes if after sugar ingestions. If that's not buffered by saliva, then demineralization keeps happening. So basically, frequency of having sugars, that's what causes the caries, right? Let's say I had breakfast today, I had cereal, it had some, carbohydrates in it. And then right after that, 20 minutes after that, I went and I brushed, right? And I had fluoride in my toothpaste, right? And I flossed and removed the plaque from in between, and I'm probably okay, right? Whereas, let's say I eat something sticky that even if I brush or I swish water, it stays there, right? So it continues to produce acid, right? Or let's say I have my breakfast and then I have a latte with a lot of sugar half an hour later, and then I have another snack an hour later, right? And then no fluoride in between, or I have. So basically, it all depends on how you create that balance. So pH is all around pH, right? So, and how we create that safe zone inside our mouth cavity, right? Inside of this area, so that we are kind of off the low pH kind of danger zone. And, same with for kids, right? So we talk about that, right? So there are protective factors, right, that get us out of that pH zone, right? Critical pH zone. The oral hygiene, fluoride, sealants, effective diet, white water, having enough saliva, right? Effective saliva. And then there are some disease indicators and risk factors here, right? I really like this one, because it kind of like looks at, the risk factors in between, but there's also disease and protective factors on the other side of it. So, saliva and sealants, antibacterial, such as chlorhexidine, which is a mouth rinse, fluoride, effective diet. Those are like, over time, they reduce the bacteria, and they, have an effect on pH, right? Increasing the pH, right? if you have white spots, if you have already restorations or enamel lesions, right? Those are kind of like disease indicators. And when there's an active decay, active disease in your mouth, the bacterial level is higher, right? So that's when you have to kind of work with the families to kind of tip this, right? Tip the balance to the other side, right? So just keep that in mind. So one of the, as I'm gonna kind of like go through these few ones to kind of like see, just get an overall idea of what are some of the things that is important to communicate with the patients and parents, right? We talked about how it happens, right? So what can we do to limit bacteria sharing habits, right? As parents, many parents are guilty of just cleaning that pacifier that just drops on the floor, and I want to make sure that my baby has a clean pacifier, so I clean it with my saliva, not knowing that actually I got rid of some bacteria and I gave her some other kind of bacteria, right? Or sharing the same straw, right? Or wanting to kind of make a food blow on the food so that it's cooler, right? So again, these are like, who knows, right? I have talked to many of my friends even, and they have like, I have no idea, right? Especially if that parent has an active decay, right? Is high risk, has high level bacteria themselves. Oral health and hygiene, it starts from early years, right? So how do you clean the gums and gums after cleaning? Toothbrush, when you start using toothbrush, right? How you use the finger brushes, just like, one of the things that I use in my educational work with the community health workers or community level folks is that tell parents to have like one cloth just for cleaning the gums, right? The baby gets used to that, and then you get used to that's part of the overall hygiene of the kid, of the infant. And using fluoride toothpaste, and what does that mean, right? If you're using it for an infant, and brushing when teeth come into mouth, starting to brush them, it's really important, and continuing to supervise that and help the kid to brush that until they get enough external strength in their extremities to be able to do a good job. So until the age 8 or 9, right? Again, that's another behavior change that many parents may need, right? To kind of like be kind of helping them with cleaning, especially those back molars that come in, right? And so supervising brushing. This is a little kind of infographics around how much toothpaste, right? Because, there's, I would say, especially with the high-risk populations, it's important to use fluoride toothpaste, right? When you go out there are some like training toothpaste, all sorts of toothpaste that may not have fluoride, or may actually, some of them have some flavors, or some of them might even have sugar. I have seen that actually. So being careful what kind of toothpaste is being used, right? And also the amount of it. If you're using that for 0 to 3 years old, just a smear, right? A small grain of rice, not a big grain of rice, right? For 3+ years, using a pea size, right? Don't give the toothpaste to the kid and say like, go for it. And, especially if they're the taste that they like, you see much more toothpaste on the toothbrush than a pea size. Anyways, but it's important to actually use fluoridated toothpaste. One other thing is that it's, just one quick tip is that it actually helps to wipe the teeth and not rinse right away. There's some literature that look at that as a practice that helps, especially in high-risk children, right? Just wanted to put that out. Not having them ingest the fluoride, right? Which are kind of like wiping it, but letting it stay on teeth a little longer. The other one is feeding practices, okay? So a little more, we're gonna have like a few more slides before we give you a little bit of mental break, right? So thank you for staying on. This is the part that I really wanna hear from my from medical providers colleagues to tell us in the chat if we are different on that, because I know there are some different recommendations when it comes to that, right? So when you look at it from the dental health perspective, right, of course, breastfeeding is encouraged, right? However, there is this with caveat of adjusting the frequency if needed, right? Especially during the night, right? So keeping it kind of like basically having longer intervals when the infant is old enough, right? And then if you're using bottle feeding, you know, holding the infant, like basically don't put a child with a bottle with milk to sleep, right? Because what happens is that there's going to be sugar and their little teeth is going to be baited in sugar for a long time, right? And that's why ECC was called baby bottle syndrome at the beginning, right? Because that's where it has the chance to really bacteria to really work on those little teeth. And you really wean them from bottle by 12 months. And avoiding like the sippy cups, avoiding actually sippy cups and kind of transitioning to the cups, regular cups easier, because sippy cups could be another kind of replacement for the bottles that the kid can keep it, and the mouth is going to be really kind of like, you know, again, baited and in sugar for a long time, right? And when it comes to juice, again, like our nutrition folks, and I know like I have worked with some of our colleagues in WIC, and they say like, we tell them limit the juice. And I was like, no, tell them no juice. And I know we want to work with the families, but you know, when you say, you know, a little juice, then people start to add water to it, you know, because their kids have already got used to the juice. And I would go with the recommendation of actually no juice, no carbonated beverages for the kids. And I have seen enough of early childhood caries that when I see that, and I have seen the direct relationship, I actually come off a little like, you know, blunt about it. It's like, no juice, no soda. That's just like a no-no, right? And I'm sure many of you guys are more know how to bring it to the parents and work with them around that, right? Drink water, swish with water, especially if you have tap water that is fluoridated, right? Fresh fruits, vegetables. When it comes to snacking, less frequency of a snacking and less sugary, right? Remember pH, right? So the frequency matters, right? And again, avoid use of sippy cup unless it has only water in it. Early and routine dental care, right? There is this goal of first tooth, first birthday. It doesn't, I'm sorry, yes, first tooth or first birthday equaling first dental visit, right? In a lot of cases, it doesn't happen. And that's why we are kind of looking at it all differently with the integration initiatives. Lift the lip. Parents can do that themselves too, as the medical providers do that, kind of really kind of like lift it and seeing the gum line, right? And being able to see how the child is doing, basically, when it comes to teeth. Fluoride, there are different fluoride modalities. There's a few of them here, right? And then I got this information from a Smiles for Life curriculum, which is designed for medical providers, amazing curriculum. But when you look at what fluoride modalities and how is it different for low risk versus high risk, right? There are some of them, for example, that, you know, like community water fluoridation, it's the same, right? High risk, low risk. Dietary fluoride supplements, if there is no fluoride in the water, the same, right? This has changed over time. There was a time that they're saying only for high risk, but that has changed, right? The recommendation, right? So as you look at that, I think over-the-counter mouth rinse is the only one that if there's low caries risk, you don't wanna kind of like start that, right? But really, it's important to look at the overall fluoride modalities that can be used. Since we're talking about fluoride, I'm just going to give you a little overview. I know I'm giving a lot of information, so break is coming in a second. So just a little fluoride confirmation, and then I'm going to give you a little more later. So what is fluoride? Fluoride is basically a natural mineral, natural occurring mineral in nature, right? In water, in some food, actually some wine has some fluoride, I'm just saying. Karyostatic, right? So it's karyostatic. It kind of like, you know, it kind of stops basically, right? The process of caries. inhibits bacteria. So basically what it does is that it reduces the amount of bacteria in the mouth, and then it enhances tooth mineralization, right? So the teeth are stronger basically, right? So they can remineralize even if there had been acid attacks, right? And they kind of arrest the tooth demineralization, right? So they kind of like stop that process of demineralization, right? So makes the enamel of the tooth a little more stable, right? So that they're kind of more strong when it comes to the process of caries. And you know, they actually increases the pH level, which is not part of that, but that's another thing that fluoride does. Yeah, there's a good point in chat that 1 year old is too old. Yes, yes. Suggesting 3 months old. Are you clarify, Mark Cave, Dr. Cave, about do you mean, please clarify, what do you mean? Is it about the first dental visits? So we can kind of talk about that among us. Community water fluoridation. Basically it's safe and it's effective, right? For 70 years, it has been, you know, the best available scientific evidence that we have. I was just actually writing the effectiveness of that. Water fluoridation is 36% to 26%, depending on the primary versus permanent teeth effective, right? And then what it is that it's kind of like strengthen the teeth regardless of socioeconomical status, right? So that's why it's going to talk about health equity. The kids who need that the most are going, everybody is going to get that, right? So that's why it's one of the kind of public health recommendation, right? It's a proven public health measure. And you know, many organizations, General Surgeon Report, and many organizations support that, right? That doesn't mean that there aren't anti-fluoridation movements. Many of you probably have dealt with that in your communities. And as providers, as we educate ourselves more, we could really be advocates for that, for the safety of that and the effectiveness of that. I usually share that with folks myself, that I was raised in my home country, Iran, and at the time of my growing up, we were in rural areas, and I was not exposed to community water fluoridation. And my siblings were afterwards. I mean, this is a case, and I'm making assumptions, but I actually attribute that to community water fluoridation. I have, you know, I have crowns and I have root canals, whereas my siblings have none of those, right? Same family, same eating habits, all of that, similar genetics. So just, you know, just community water fluoridation and its effect is real. And that's why I'm sharing this story. Fluorosis is one area, one side effect, and the only side effect actually of fluoride. However, it, you know, this when it's a mild fluorosis, it's just a shape in the color. When it is moderate to severe, then it changes the tooth structure. So we want to be careful about that. Fluoride varnish is not associated with fluorosis, right? And mild or severe only happens, and even the mild actually version happens when there has been chronic exposure to fluoride, like if there has been a well who you know, that the fluoride content of that well hasn't been identified, it has had like a high level of fluoride, right? But community water fluoridation as 0.7 level, it's pretty safe. All right, so ready for a poll. How willing are you to advocate for community water fluoridation? Again, we haven't shared a lot here, but I was just wondering, just knowing about this and the impact of it of our population, how willing are you to advocate for it? Like, go to your city council and say, you know, this is important for my community. Like, let's say as a medical provider, I know how it's important for my community, right? So, and you know, again, there's no right or wrong answer. You might say that I need to learn more to advocate for this more. So I just wanted to get a pulse of the population of the small population here. Great. I already see that there are some people who are willing, and there are some that are very excited. Thank you so much for that. Thank you. Great. And there's some that they're not convinced yet, and there's some who are neutral. Thank you. Thank you. It's really good to know. Fantastic. So I'm assuming I'm going a little slow, so I'm going to just go a little faster here, right? So that we kind of like cover the elementary school and teenage years as well, so that we can, and then we can get a break. So we talked about early childhood, and as we talked, it's a continuum, right? So when it comes to elementary years children, you know, again, the same thing, start early, healthy eating and snacking, drinking habits. And, you know, you as, you know, medical providers or, you know, other professions, you are already working with patients around, you know, some of this, right? It's the work that we're already doing around obesity and diabetes. So how can you kind of tag on dental into this? Developing self-care skills for a child in elementary school and teen years is important. Safety when it comes to sport activities and protection of the teeth around sealants. So let's talk a little more on that. This is sealants. So what sealants are, these are most effective in permanent teeth, right? Permanent teeth start coming into the mouth around age 8, right? And you know, there's this fissures and grooves in the teeth, like, you know, imagine the mountains and the valleys. And when you seal that area, basically the bacteria has less chance to kind of get stuck there, right? And that's where it's the most effective, right? So sealant is actually the most effective public health measure when it comes to permanent teeth, around 80% effectiveness, right? So it's one of the best we have got. So it's important to encourage parents to do that. And it's better to put them soon, right? When they're like brand new teeth in the mouth, you want to kind of seal them off, right? Before the bacteria has a chance to start demineralize the teeth structure. Here's some great, just for your information, and we will share that later. It's a great resources through Glenn County that they have developed around sealants. Some teens dental concerns here: braces, wisdom teeth, oral hygiene and gum disease. That's a little more prevalent around teens. HPV, smoking, mouth jewelry, meth mouth, eating disorders. These are the things that, you know, that are kind of areas of oral health and overall health coming together, right? So contact sports, just encourage them to wear helmets, right? If a dude gets knocked out, right, and they come to you, do not touch the wound site, do not touch the tooth itself, because the cells are still alive, right? So, and just like keep that tooth in some milk or a moist cloth without touching the structure so much, and send them to the, you know, do not rinse the tooth, send them to a dentist, right, within 30 minutes. And they could, most of the time, reimplant the same tooth, right? Never reinsert a primary tooth, I would say, as primary care providers, unless you have been trained in that. I wouldn't say you try to do that yourself. Just make sure they get to a dentist within 30 minutes. Substance abuse in teens, it's a big concern among our adolescents, unfortunately. Meth mouth is a condition that, you know, meth is one of the most destructive substances out there, right? Alcohol as well as tobacco, all of that create lesions inside the mouth that can lead to gingivitis, dry mouth, and increased risk of future cancer as well. So just really kind of working with the dental providers around these to address this. HPV, right, can cause serious health problems, including warts and cancers. So really, you know, HPV vaccinations happens in the primary care offices, but just like that's another one that is an area of oral health and medical health coming together, right? Because that causes 70% of oropharynx cancers. Okay, wow, all right. So we are here, we are ready to take a mental break. And so what I would like to ask you to do is to do a little bit of a stretching, right? And I'm just going to review some of the chats here. That's great. Yes, sealing primary teeth is also great. No contradiction, right? Sealants are more effective on permanence, but actually on primary teeth they are effective as well. That's fantastic, right? And dental providers administering HPV vaccine is great. So yes, time to stretch, take a deep breath. If you need to stand up, I'm gonna stand up myself. And Susie is gonna just put a fun video for us here around the power of validation. So how can we use
Yeah.
that?
Do you want to stop sharing your screen and I'll share mine?
Sure, thank you so much for that. Yes.
Here we go.
I'm here to get validated. You are awesome. Excuse me? You have an amazing face. You've got powerful features, man. Anyone ever tell you that? No. Then listen. You look a little down. And it may seem like sometimes people don't understand you. But someday, man, someday, people are going to see you for what you really are. You really think so? Absolutely. You are great.
Need a validation, please?
You are great, ma'am. You have amazing cheekbones. Sure. Yes. We have a situation. Where?
Oh my God. 6 months over.
What the hell's going on? You've been through it. You know. You've had so much life experience that other people don't appreciate, but you know.
Plus you do.
They're not patronizing the shops. They're just coming to see him.
Oh, sir, you're in great shape. You work out?
Not for long.
I do, actually.
Yeah, thanks. Young man, we are running a business here, not a social club.
That is a fantastic suit. It really flatters you.
You think so?
You guys work so hard. You are the backbone that keeps this place running.
It always felt like no one really appreciated us. Yeah, I mean, our jobs are so stressful, and it seems like most of the times people just don't see it.
No, what you do is so important.
You know, I bet the boss would love to meet you.
You are great. You provide hundreds of jobs, sustaining hundreds of families. That's huge.
That's so good to hear. Most times I feel like people don't recognize that. I'm just the big bad man on the hill.
Not at all. You give.
Oh, my Lord.
You know, I know some people who would probably like to meet you.
Mr. President, no matter what people say about you, you have still got a great golf swing. God bless you. You do. You have a fantastic mustache. I bet Burt Reynolds and Tom Selleck look at you and get envious. I'm not kidding.
Thank you.
You're welcome.
Hugh Newman, a man who's changing the world with free parking and free compliments.
A very
Thank you so much for that, Susie. I'm just gonna start sharing my screen again. Great, everybody seeing that screen there? Great, I'm assuming that's yes. Hope you had a little bit of break here, and again, feel free to kind of stretch and bring up, refill your coffee and tea, and we're gonna continue for another hour and a half. So, okay, so let's see. So we talked about, all of these, and now we want to kind of talk about the elements of oral health integration, right? So what does it take? How do we integrate that into a well-child visit, right? So these are some elements that we're going to talk about. oral health assessment and risk assessment or risk identification, right? We're going to give an overview around that. Fluoride varnish and other fluoride supplements, just a little more information on that and how to apply fluoride varnish. Oral health education and anticipatory guidance, and how to integrate that into what you folks do in your medical practices, in medical care, and referral to dental care. And role of a staff and office flow and clinic flow, and then billing. It's, you know, how to make this sustainable, basically. All right, so oral health assessment and risk assessment. So this is a forum through American Academy of Pediatrics that has been widely used. There are some other forums, DTI, which is a dental transformation initiative through the medical program, came up with another risk assessment form a few years ago, and that has been popular as well. So, but I think from what I have heard, a lot of medical providers still use this one. And what it does is that it looks at the risk factors, protective factors, and clinical findings, and based on that, there's a little bit of risk assessment, right, of what's going on with the child. So as you see here, we have something like mother or primary caretaker has had any active decay in the last 12 months, right? Why does it matter? Because that means the level of bacteria is high, right? And the vertical transmission is happening here, right? Transmission of bacteria. Again, kind of look into etiology and the whole pH thing as we go through this, right? To see what it makes sense. Or mother primary caretaker does not have a dentist, you know, for the same reason, right? Continued bottle sippy cup use, frequent snacking, these are part of the risk factors. Some protective factors, you know, if a patient already has a dental home, right? There's a place that's already going, right? That's the protective factors. They drink fluoridated water, or they take supplements, or they have had fluoride varnish in the last 6 months, or they, you know, they brush their teeth with fluoridated toothpaste twice a day, right? These are all protective factors, right? And then you do your clinical assessment, right? If there are white spots, obvious decay and restorations, anything with this little triangle means that's that immediately puts somebody in the high risk, right? If a child has a white spot or visible decalcification, right, in the last 12 months, if that's yes, that's already high risk, right? So all of these are with a little yellow triangle. That's what it is. This is the rest of that form, right? As you see in the first column, some of the risk factors: continual bottle sippy cup use, right, with something other than water, right? So frequent snacking, special healthcare needs, right? The kids who are have a special healthcare needs, unfortunately, most of the time they're high risk if they're Medicaid eligible, right? So. You know, there are on the last column when you're doing clinical examination, there's also things around if there's any plaque accumulated, if there's like a gingivitis, right, swollen gums, and you know, if there are healthy teeth or teeth present, right? So this is part of like looking at the whole math area and then seeing like what's going on. So some of these risk factors, right, as we talked about in the last slide, but just like having them in one slide, right? One thing I want to focus on here is the continued bottle sippy cup use. It's one of those areas that takes coaching. And again, in a medical practice, you know, this can be done with different staff, right? Like the health education anticipatory guidance can be done by, you know, somebody could do fluoride varnish application. Let's say pediatrician or nurse practitioner does a fluoride varnish application, and the medical assistant does the anticipatory guidance, for example, right? So, but these are the things that as a team we can really look into. And the dietary counseling around the sticky food and carbohydrates, and you know, and drinks and water, that's an important part of that as well. All right, so that's the risk factors, protective factors, what's going on if they have dental home. Again, we talked about that, right? And again, as you get, you know, many of those you already, from what I hear from my medical colleagues, you're already doing that work. You're already asking, in your obesity or your diabetes screening, you already are asking, looking for those. So kind of like having just the dental frame of mind being added to that, right? If fluoride varnish, just knowing about like what has been, like when we talked about systems, if you have systems like ladders in place, it's helpful to know and connect to other providers, from medical to dental providers, to know about that as well. Why is it important to do risk assessments? Because again, 80% of ECC happens in 20% of children, right? So you want to know what's the risk of that child that is sitting over there, right? So that based on that, you'll say how important it is that they go and see the dentist, right away, right? Use of fluoride and fluoride supplement, right? If it needs to happen more often, fluoride varnish needs to happen more often if it's a high risk, right? And also the counseling, if it needs to be more powerful around that, right? So basically, the starting of the risk assessment gives you an overall picture of what's going on with the child, and based on that, adjusting your level of efforts around that, right? And it should start around 4 to 6 months of age. And again, when you look at the risk assessment, then based on that, you do your overall assessment, right? You can do your visual assessment. You can ask about the chief complaints. A child, might have a tooth pain, and they may not be able to identify that, right? But there might be, so you have to kind of look into that yourself too. So the complaint may not always be direct. That's what I'm trying to say. And identifying problems that need to be referred early, right? So if there's caries, poor oral hygiene, developmental abnormalities, you want to be able to see those, right? And we're going to look into some pictures to give a little bit of guidance. And I'm hoping with the references that we give, you will feel equipped enough to be able to do that, right? And then again, assess risk for future problems. So when we look at the teeth, primary teeth, there's 20 of them. And then there's 28 to 32 permanent teeth, right? Depending on if a child has permanent, wisdom teeth or not, right? And eruption of primary teeth starts around 6 months old and goes all the way to 2.5 years old. And then a 3-year-old usually has beautiful 20 little pearls in their mouth, right? And if they're healthy, they really look like pearls. And around 6 years old, the permanent teeth start coming inside the mouth cavity. And, they start with the back molars, and they kind of like it continues, right? It kind of like it's a continuous process, sometimes goes on up to 21 years old when the wisdom teeth come into the mouth, right? So that's a little bit of like an overview of just like what our teeth, like this set of teeth that we have are about, right? And when you look at the anatomy, apologies. When you look at the anatomy of a tooth, here you see there's enamel, which is the hardest part of the tooth, right? And protects the internal part of the tooth. Then there is dentin, and then there's pulp, right? So when the demineralization happens, it starts from the outer part of the enamel. But if it gets remineralized or gets detected early, then that stays on that level, right? If not, it starts cavitation, means it starts kind of eating up from the tooth structure. And when it gets to dentin, then it starts to actually advance much faster. And when it gets to the pulp, unfortunately, that's when the infection and the bacteria starts, goes into the bloodstream, and it goes into the arteries and nerves over there, right? So just it's kind of like good to keep that in mind, and also kind of keep the anatomy of the crown and the roots of the tooth in mind when you're doing your assessment. Here's a dentition of a 6-year-old. As you see, there's all of these primary teeth over here, and there's the buds of the permanent teeth down there, right? And they actually look like this. They don't have the roots developed yet, the primary teeth. And as they develop their teeth, the roots, they start coming out and absorbing from the roots of the baby teeth. And that's why baby teeth become loose, right? And they come out. This is permanent teeth, right? And there's kind of like a wisdom teeth that are coming out here, right? So when you're doing visualization, you're actually looking for a few things: soft tissue and hard tissue, right? And again, as medical providers, we're all used to look into that. What is the color, consistency, shape? Is there any decay? Is there any plaque around gums, right? Is there any inflammation? Does it look red? Does it look pinkish, right? Past fillings, right? Is there fillings over there? Are there missed teeth, right? Again, kind of like getting used to what's going on in that cavity of the mouth cavity and kind of like where to go from that, right? How to interpret those results. This is an early years healthy mouth. This is an age 1 beautiful gums. I'm sorry, newborn kind of beautiful gums. And then after that to the right, a 6 to 12 month old, kind of like a cute little upper maxillary incisors and lower incisors, mandibular incisors down there. And as you kind of see, age 1 has a few more coming out, and it comes to age 3, most of the primary teeth are out. So it's one of the cutest things out there, maybe because I'm a dentist. Here are some pictures of a healthy mouth on the left, and then here on the right, when the restoration is present, right? Restoration could be a crown like this, like a stainless steel crown. It could be a filling, right? But this is how the restoration looks like. Okay. And apologies for the quality of these pictures. But here's the plaque present. Basically, plaque is like this area around the gums, and it's kind of causing inflammation to the gums as well, right? To the left. And then here's an active decay that has had the cavitation happening here, right? Again, just giving you some pictures to kind of like start familiarizing yourself to what to look for when you look inside the mouth. Here's again an active decay and white spots, right? So those white spots pieces actually is the one that if you kind of work on it with a combination of fluoride varnish application and dietary counseling and all of that, we can manage to reverse. And then active decay with cavitation again in the right. Here are some other examples of advanced early childhood caries or advanced decay. In the upper left, as you see, you don't see any active decay right there, but you see a dentition that is missing these front teeth, right? 4 maxillary incisors, we call them, right? Those 4 front teeth, upper teeth. And you can tell they have been extracted due to severe caries, right? Otherwise, a child this age should have had those like others. And what happens when this happens is that the dentition usually uses its space for permanent teeth to come out, right? So that's when that's one of the functions of the primary teeth, to keep the space for the permanent teeth to come in the right spacing in the mouth, right? So that child, you can tell, is not gonna have that. And advanced early childhood caries, as you see, is like it's advanced. It's all the way to the pulp in most of the cases, and in some cases you can see an abscess next to it, or in the vestibule or other areas of the mouth. Again, another kind of like progression of mild to moderate and severe, and knowing that progression can happen really fast. So we want to kind of keep it when it is at the mild stage and intervene then. Or do prevention before that, do risk identification before even it gets there. Okay, that was a little bit about assessment. I know it was not enough, but it was just an introduction, and I'm sure when you get started, you will have some questions. So if you have questions right now, please put them in the chat, and we'll be happy to answer. Okay, the fun part, fluoride varnish application. This is really fun. We usually, in order to do that on a young child, you use a knee-to-knee position, right? Here you can see a provider and the caretaker provider kind of sitting knee-to-knee, and the child can see the mom, right? And kind of is holding their hand, so the child is not going to their mouth, and then they're providing for advantage application. And all you need is what is here, basically. That's all you need, right? If you have a mirror, great, but you don't really need that, right? All you need is a pair of gloves, white varnish, and some gauze, right? So, the time of COVID, definitely your masks. So let's look at a quick video here before I talk a little more. So I'm gonna stop sharing, and Susie, you can share the video.
When applying fluoride varnish, you want to get the child in a safe and comfortable position. Turn the child around so she is facing her mother. Tip her back onto your lap and place her legs around mom's hips. Mom should hold her hands. Julia has no back teeth yet, so we will only need to apply the varnish to her front teeth. Dry the upper front teeth with gauze and paint on the varnish, covering all the teeth. Try to keep the tongue out of the way with your fingers. We're using cavity shield varnish here. Young children often cry when this is done, but this means their mouths will be nice and wide open. Now dry and paint the bottom teeth. Here, it would be helpful to use your finger to keep that tongue out of the way. When finished, clean her face and sit her up. Older children have more teeth, and you will have to start by applying the fluoride varnish to the back teeth. Dry the teeth in the upper left corner of the mouth with the gauze and paint on the fluoride varnish. Be careful to hold the tongue and cheeks out of the way. In this case, we're using Enamel Pro varnish. When finished, move down to the lower left corner of the mouth. Again, dry the teeth and hold the tongue and cheeks out of the way and paint on the varnish. Move across to the right side and do the lower and upper corners of the mouth. Frequently, we do not do the lower incisors as they rarely get cavities. As you paint on the varnish, make sure you cover all the tooth surfaces. Once the varnish is on, you do not have to worry if it gets wet, as it sets on contact with saliva. Paint the upper incisors last, so that you do not accidentally wipe off the fluoride varnish as you work in the back of the mouth.
Fantastic. Thank you so much, Susie, for that. Yeah, as you see, and it's easy. It's really easy. And when you have a young child and they have just few teeth, you know, all you need to do is really kind of like put the gauze and kind of behind, just go really fast, right? And what I usually do is that I start with, like, say if there's like a 1-year-old that has 4 teeth, 2 top, 2 down there, I just keep the gauze on the back, just do the front of the teeth, right, and the back of the upper teeth, and then the front of the lower teeth, and then at the end I go inside of the lower teeth, just in case there is a taste or the consistency for it varnish that the infant is gonna respond to. So that I do the lower the lower inside of the lower teeth at the end, right? And then as you're doing it, you're just like using the gauze to dry and at the same time to just kind of like retract a little bit. And it doesn't have to be super dry, just a little bit dry, that's enough, right? So that's how we go about it. Very easy. Again, very easy. There's some other areas that do that. These are some of the fluoride varnish out there. I have borrowed these from our Sonoma County integration webinar presentation they have had a few years ago. And the cost of these are around $1 per unit, right? And we're going to talk about billing later. And when you look at it, the reimbursement is around, if you are in that category that can get reimbursement, it's around $18. And this is cost around $1. So it actually makes sense financially too. So it's when we talk about effectiveness and frequency, really, it's really like when you do your risk assessment and you look at the whole picture, it's really important to look at that. There's a disclaimer to know that fluoride varnish is off-label and is licensed for tooth sensitivity. However, there's many products that we use off-label, and this has been effective and has been used in many countries for many years. So studies has demonstrated that there are 30 to 35% caries reduction, right, in many of it. And there are some studies that they show that even with one application, there is change, right? But there are some that they have shown that you need to have at least every 6 months. And if you have a high-risk child, then you actually could, the frequency of that fluoride varnish could be as much as 9 to 10 times a year, right? And even more, I would say 9 to 10 is the safest without kind of causing the risk of fluorosis. And you could go, like, you can every month and a half you could apply fluoride varnish, especially if the child does not have a dental home, right? And they're not going there. And the thing is that, when we talk about different fluoride supplements, and I'm going to tell you a little more right now, but when you look at that, you have to look into kind of assess what's going on, and as far as like are they being exposed to other fluorides, to see if you're going to give them fluoride supplements or not, right? So, but regardless of that, the fluoride varnish application is safe, and you could really, in high risk, have the higher frequency. And there are some new articles that has come out around that, and I can, through CDA, and I can share that with you all.
Dr. Mazade, I don't mean to interrupt you, but we did get a question in the chat. Do you varnish teeth that appear that they have cavities forming? All of these children's teeth look great, but what about those that do not? Do we still varnish?
Oh, yes. Thank you so much for that. Yes, I'm going to talk about contradictions in a minute. And if a child has an active decay that has gone to the pulp, right, to the pulp of a tooth, then we don't, right? If it is a cavity that is a shallow cavity and it hasn't gone all the way to the pulp, then we do. White spot, we definitely do, right? But if it is a bigger cavity, then we don't, because then it's an acid, right? You put that and it's going to go, and it's going to go right to the nerves of the teeth, and that wouldn't be recommended. But otherwise, yes, you do. And that's actually when it is the most important to do, especially with white spots and with the small cavities. And thank you for that. And then bring them on if questions like that come in. Thank you. What it does, the effectiveness of that, what it does is that it strengthens the enamel, right? And it stabilizes the enamel, basically, right? And it starts the process of remineralization if there is some demineralization that have started, right? And really, again, there was some recommendations from United States Preventive Services Task Force that they say that the primary care clinicians really can start doing that when the first teeth come, right, all the way to age 5, and at least every 6 months, right? Again, for high risk, we want to go higher frequency, right? And it's a grade B recommendation, so it's a high level of recommendation. And again, there's some recommendations that say every 3 months, but again, it's going to be safe to go more frequent than that as well. And contraindications, if the child is allergic to pine resin, there's some studies that say even with that, that's okay. But again, that there has been some study that show that because that's where the fluoride actually has been extracted from. And don't place in deep pulp exposures, and do not apply if a child is experiencing stomatitis, right? So if you look inside a child's mouth and you see, stomatitis, then you do not want to put fluoride varnish in that mouth. These are some brochures that have come out through CHGP. I like them a lot. They are very succinct. They have, what you need to know, what the patient and the parents need to know, right? What it is. So it basically explains what you do to them, right? It can be applied at both child visits or dental office. It works best when applied 2 to 5 times a year, right? Can be applied as soon as the first tooth comes in. And it's actually really effective on the children with the special care needs. Post-op instructions. It's okay to drink water. Look into the manufacturer's instructions, because different fluoride varnish are different, but in most of them follow this, that after that it's okay to drink water. Don't have food that are too crunchy, like don't have nuts or chips or chewy stuff, right? So that it kind of like mechanically it stays around the teeth, right? And then don't give something like too hot so that it doesn't wash it away. And that night, it could be the only night that they skip brushing, actually, right? So they kind of skip brushing and then they start brushing again the day after, the morning after. Again, this brochure is here, and we will kind of like put that in our toolkit, all of these forms, so you have them. Let's kind of give like a quick post-op fluoride varnish to your patients afterwards. How you prepare for that. So if I have a young child like that, and the child might be crying, right? And by the way, if a child is crying, I mean, you just want to go there for a minute and come out, right? So if a child is crying, sometimes it might actually make your job easier, because the mouth is already open and just need to just dry a little bit and again go in and out, right? So, but before you go in, have your kind of varnish gauze and kind of like some good source of light, right? Or at least a well-lit room, right? Knee-to-knee position, right? Have the caretaker help you with that, with the knee-to-knee position. Take a quick look inside the mouth, right? How is the hard tissue doing? Kind of like lift the lips, like lift the gums, right? And see, do you see anything? As you know, as primary care providers, you are very much used to looking into the overall kind of throat and overall, area over there. So as you're doing that, just look inside the teeth as well, right? So you see white spots, how oral hygiene, is there any plaque over there? How is the soft tissue? Again, if they don't open their mouth, just kind of slide your finger in the buccal sulcus over there, apply a little pressure, and then they will open. So who can apply fluoride varnish? Basically, dental professionals, physician and nurse practitioners, nurses or medical assistants, they can do that with delegation with RX and check the billing and see how it works with your billing. But we can do it as a team. This is, again, I've talked about this, but there's some supplements and what is the appropriate dosage for that. One thing that is important to do before you prescribe any oral supplements, especially because we're talking about populations who don't have fluoridated water, is that here you need to know what's the source of patient's water, especially if there's well water. There might be some well waters that have actually high level of fluoride. So be a little careful about that. You know, if you could kind of like, you know, have that and then see what's the fluoride level in that well water, and then kind of repeat that over time. And you know, talk to your dentist in your area and see what are some of their observations around well waters in your area and the fluoride concentration in the area, right? So that's really important before you prescribe any fluoride, right? But then after you do, you know, if I have to determine the fluoride content in the water through that, then you can kind of like trust these prescriptions guidelines, right? Additional factors affecting is, you know, if they're using any filters. There are some filters that remove the fluoride, but not all. Most of the filters don't actually. And then water bottles, again, some of them do have fluoride, but most of them don't. All right, so thank you so much. I'm gonna give you a break from me and invite Andrea Andrea, I'm hoping I'm saying your last name right, Shulkin, to the floor. Andrea is a nurse manager at Northern Valley Indian Health, and they're doing a great job incorporating oral health into their well child visits. So we want to hear from her and how they're doing it in real time.
Okay, thank you. I can't turn my video on, Susan. Oh, there we go. Here I am. So yes, again, my name is Andrea Shulkin. I am the nurse manager for Northern Valley Indian Health. I have been here for about 5 years, specifically at the Children's Health Center. We focus solely on pediatric primary care. And it was funny to me actually that I was identified as a champion for, well, not me, but my clinic, because it's sort of always been what we do. It's part of our well child appointments. And so it was interesting to me to find out that this isn't common practice for a lot of pediatric practices. So anyways, I was asked to just kind of talk about how we do that and how we integrate that. So we can go to the next slide. For our clinic, and actually we've adopted this it looks busy, and I do apologize for that. This was adopted for all Northern Valley Indian Health clinics after the Children's Center started utilizing it. We've asked our family practice clinics to try to use it as well. So what we've done is outlined at each well child appointment which tasks need to be done. And you can see by all of the red circles that we start fluoride varnish essentially as soon as teeth are present, as early as 6 months, or even possibly at 4 months if there's teeth then. And even if there's one little tiny tooth, we'll paint that one with fluoride as well. You can go to the next slide, and it just shows that it continues on for our older kids. We do this up to the age of 15 years old. And the reason for that is these guidelines are kind of a mix of what the American Academy of Pediatrics, Bright Futures recommends, and then what CHDP, or Child Health and Disability Prevention Program, has requested that we cover in our well child appointments, as well as what Indian Health Services, or IHS, identifies in their GPRA measures, which stands for Government Performance and Results Act. And those are things that are specific to Native American patients that that IHS wants us to make sure that we're identifying at all of the appointments, and that includes adults as well. But fluoride varnish is something that we've identified that we can do during their well child appointments, and so we do that. And because these, this population doesn't generally have a dental home, we try to encourage that as early as possible. It doesn't always happen, as Dr. Imanzadeh mentioned. It is hard to get into providers that take Denti-Cal. So we can give fluoride as often as every 3 months. And so if a patient is identified as not having a dental home, we will offer the fluoride, and generally the parents are agreeable. There's some that are not, but they do get the added benefit of taking home a toothbrush and some toothpaste and some flossers as they're age appropriate as well. So you can go on to the next slide, and I'll show you how we have entered the information. Most of what's in this is this is a screenshot of a template from our electronic medical record. We use eClinicalWorks, and we were able to include the information that CHDP requests in their care coordination form into our template, so that as the providers and nurses are documenting, all of that information is right there. This acts as a reminder to the providers to make sure that they are doing that risk assessment and addressing that with the parents. So if you go to the next slide, you can see where, so some of the information that was in that oral health section is pre-populated, and then you can click on it, and there's these pre-populated answers that a provider can click on. And generally the dental home, actually the nurse addresses, and the Carrie's class, the provider addresses when they see the patient. So yeah, there's the different options, and then you can also free type in there if needed to make the answer appropriate. And that just makes it a little easier to keep that integration going. We can go to the next slide. This just shows the order sets that we've created, and we have a different order set for each age. You can see at the top, this is for a 2-year well child appointment. And the fluoride application is in there along with the various other things that we do. If this was a different age child, you would see a whole list of immunizations for our older kids. That includes the HPV vaccine. We cover that actually as sort of, we don't really ever ask if the patient or parent wants to give the HPV. We just say they're due for their Tdap, their HPV, and their MMRV, or whatever. They're not MMRV, excuse me. Their meningococcal vaccine. and it just makes it part of, you know, our process. And so there is less opportunity to forget, and it's just a part, again, it's part of what we do. So I think the next slide shows how once the order is entered into our template, it shows there's a screen for the nurse to document that they've completed it, or they can document that it was not done because maybe they just had a dental appointment or parent refused or whatever the case may be. But when the fluoride is applied, it automatically adds that procedure code into the procedure codes for the entire visit, and we bill for that. Most of our patients are Medi-Cal, so generally we are reimbursed as a flat fee, but we try to put all of the billing codes in there anyways. Trying to make sure I covered everything. Again, it's actually a pretty simple process for us. We have tried to embed it into what we do so that there's really no second thought to it. We just kind of get it done, and it's easy, and the nurses like being able to give the toothbrush bundles treats afterwards. We do generally have the nurses do it at the beginning part of the appointment during their intake, because there's this, generally they ask for about a 30-minute wait time before they eat or drink anything. And then the provider can come in and do their assessment. And then the nurse will then come back in and give any vaccines that are due. And it seems, I was laughing as I was making notes. It's a little counterproductive because we give otter pops to our kids after they get their vaccines. So we've treated their teeth with fluoride, and then we give them a sugary popsicle. But we try to do what we can to keep them happy. So and coincidentally, my son, who's 10, had a well child appointment recently. So we went ahead and did fluoride for him at his well child appointment, just so that we could get a video of sort of how simple it is and how quickly it gets done. He generally sees a dentist twice a year, and we do it there. But for the sake of being able to show a video, I went ahead and did that. And I think Susie is able to share that video. And this is one of our clinic nurses who is applying it.
I think you can share, Susie, now.
Okay. So. Good job.
Buffering.
Looks like it froze.
Yeah, let me try that again. I'm going to stop screen sharing for a second.
Oh, I could briefly mention, generally, if we have providers who do notice any urgent dental needs in patients' teeth, they will put in a dental referral for surgery, and those referrals are processed through our clinic, usually within a day or so, and they generally get appointments within the week. Unfortunately, they tend to have to go to Sacramento for dental surgery. There really isn't a lot available in the Chico area.
Okay, let's see if that.
So. Good job. Okay, now I'm going to move on to the next teeth. I might need a little bit more in the back, right here. Okay, so on your bottom tooth, okay? you see okay?
Yeah.
Andrew? Okay. Good job, good job. Okay, leave it open. I'm gonna grab the other piece of the gauze. A little bit more. You're good, doing so good. Okay.
And generally, I mean, and that's, I see the comment about applying to everyone. And I think we used to go only up to age 5, and we started going up to 15 when I think IHS identified that as the age they wanted us to go up to. And I think the hope is that generally the older they are, the better access they have to dental care, and that it will get taken care of through their dental provider. But it is definitely still an issue, and something, you know, there's always room for improvement, and that's definitely something that we could probably make a point to try to do more. But other than that, unless anyone has any specific questions for me, that's really all I have.
Thank you so much, Andrea. And we are going to have a question and answer section that we're going to bring Andrea back for any questions. And it's amazing, you know, they are just doing it so easy, so seamlessly, and it's just great to see. So I'm going to just cover a few more aspects before we have a Q&A section at the end. You know, after you do the assessment and the fluoride varnish application, then just oral health education and anticipatory guidance. Again, we have talked about it, just kind of emphasizing on that a little bit more here. Just understanding where families are, sharing the risk assessment, and then empowering them, making a change. Again, this is like behavior changes that embed in many other changes. So just keeping that in mind as you are offering those health education materials or prevention facts. I'm a big advocate for motivational interviewing, and I think that goes a long way too. Again, these are some great brochures from Glenn County, and this is some forums for anticipatory guidance, a kind of goal making, goal setting that you could use, again, depending on the age of the child, you know, and you can work with the families to set some of these goals and see which one of them kind of like are the priority right now and work on those. Another thing that I wanted just to mention just quickly around pregnant women, you know, really kind of, you know, especially if you are working with your other medical providers, with OBGYNs and prenatal care providers, kind of working with them as well around prevention of oral health disease in the pregnant women and that population. Some recommendations for parents is that, you know, caretakers really have to take care of their own teeth, right? Make sure they see dentists when they have, you know, as both as a preventive and also when they need to, and, you know, limiting the frequency of sugars, using toothpaste, using other agents, preventive agents, such as topical fluoride and antibacterial mouth rinses. And really monitoring and brushing habits until they're 8 years old. This is a piece that many parents miss. And kind of like supervising brushing at night and things like that, and making sure the sealants are put as soon as the permanent teeth come out, and making sure that they get assessed as kindergarten entrance. That's an initiative through schools, a kindergarten assessment, and I think that's very important to also follow that. So now that comes important to referral to dental care. As Andrea talked about, really referring to a dental home is an important part of this whole thing, right? And I really encourage my medical colleagues and my dental colleagues and my public health colleagues to create connections as much as possible, right? And those go a long way, right? If you could kind of pick up the phone and call somebody, a dental clinic just right, 2 blocks down the street, those local connections go a long way, right? And, in the rural areas, we have to go beyond that and create those connections more regional wide. And the urgency of the referral based on the assessment that you do, kind of like work with the CHDP providers, CHDP nurses through the Department of Public Health around that, in the different areas that could. This is an area of public health that we need more work on, the referral of dental care. But there are some resources out there, as far as like giving you help with that. In the meanwhile, kind of building some capacity, kind of like having the list ready and kind of knowing where to refer to. Butte County CHCP has a kind of updated list of providers. Here's a link. You're going to have this later too, so you can use this link to get updated list of the providers in the area. And then billing. Okay, this is the best part of this presentation. So depending on the financial model of your organization, it's a little different, right? If you look at the CPT codes, the code 99188 is the code that you usually hear for fee-for-service or for other billing, but that's the code that's usually being used. The reimbursement for fee-for-service is $18 per application. If you're managed care medical, then it varies, right, depending on if you're fee-for-service or independent practice association. And I'm hoping our managed care representatives on the call, if there was any questions, they could answer any questions you have in the Q&A section. Really with FQHCs, in most of the cases, there's not a separate procedure. It's part of like a wraparound kind of like a billing part, but there are actually ways to work within the system to have it added as an add-on, and I have seen that happening in Alameda County and in some other counties. Proper coding sequence, these are some information for you. You will have this, just take a look at that. I'll go a little fast through this, but you will have this. Looking into the flow, office flow and cost effectiveness, really kind of scheduling them, doing this as a team, time management. I have seen practices that do that in less than 2 minutes, actually 1 minute and 40 seconds. They kind of get the whole thing done, right? And kind of like, again, integration into the electronic health records, as Andrea showed us how they're doing it, so that it's kind of part of the work that they're already doing, the reporting that they already need to do, so that it's not okay, one more thing that you need to do. Really kind of combine that with our parallel work and doing, and kind of like looking into the cost effectiveness and figuring out the reimbursement and stuff so that it's sustainable for you. There's some examples of some forms that some other clinics have used. We'll be happy to share all of these with you so you can use this as models, how to kind of incorporate oral health screening with vaccination, right? So that you can kind of like do a nice kind of check-in for the parents, right? What are the medical milestones, dental milestones? This is another form, again, with fluoride varnish application and the kind of like a summary notes of the exam and all of that. And I wanted to spend some time to talk about aligning our systems. As everybody talked to you during the last 6 to 8 months, we really worked on bringing different partners together. Talking to our local CHDP partners, right? Talking to our local managed care organization, emailing our local clinics, right? And kind of like trying to build this, and that's what it takes, right? And I know we are still at the beginning of this, but that's what it takes for us to really have an integrated system, and the integration has to happen at the local level, at the higher level, but right now we're talking about advocacy and working together at the local level. So just to give you some overall information, and I'm just going to go fast through this, and you're going to have this again to look at them later. Child Health and Disability Program, right? They are basically responsible for dental follow-up care coordination of medical fee-for-service, right? As you know, dental is fee-for-service for most of the counties other than Sacramento and LA County, right? But other than that, dental part is a fee-for-service. Medical part depends on where you are, and then but the dental kind of follow-up and care coordination goes under CHCP to help the providers when they are fee-for-service. Medical managed care plans, providers and beneficiaries, there are some talks and some bills around they being more involved in that aspect of the care and provide more support. But that's in the works. But locally, when you talk about what CHCP has done, the Butte County CHCP, Amy, who is on the call today, really shared with us how they have been involved with fluoride varnish assessment training with CHCP providers and their staff, provided oral health educational materials to the clinics, and conducted presentation and outreach through the county, right? So, so they are there as a support for you, and moving forward, they continue to be. This is a form that can be adopted. We got it from Sacramento County, but different counties can do their own version of this form, adopt it to their own county. Foster children, there are some work that can be done to do the case management of the foster children, and dental needs to be part of that, right? Managed care organizations locally, Anthem Blue Cross and California Health and Wellness Program that we have worked with, they're really aiming to work with providers and Department of Public Health, and then recently with oral health programs as we started to talk, and also local CHDPs to see how they can support these initiatives. And this has been really heartwarming to see that we can actually work together. There is, this is like an tangent, there's a value-based payment through Department of Healthcare Services Agency that was brought up about a few years ago through DHCS. And this has dental fluoride varnish application is part of that. And they have $25 to $38 based on the risk level reimbursement. I believe that I'm not sure if it is in addition to other fee-for-service reimbursement that you get, but I just wanted to share this resource with you to have. So as far as our work with these two amazing managed care organizations we have worked with, Anthem Blue Cross Medical really works with the medical providers to have the oral health as part of new provider orientation, and then also has it as part of their set audit and quality review. When they do case management in the cases that the dental anesthesia referral is needed, or in the cases that there are needed to be incorporated into other areas of case management, such as nutritional counseling and other areas, they do this holistic case management and include that into their services. So it's also transportation to dental appointments, or they have transportation services, and that can be used for dental appointments as well. Again, you have this, there's some of these, there are forms that we're going to share with you in the toolkit that we're going to provide, and you can use if you are part of Anthem Blue Cross. There's the transportation information. This is a case management form, referral form. And in addition, California Health and Wellness that we have worked with, they also disseminate some information and services through their provider bulletin. They also, but for dental anesthesia, they need a prior authorization form that we're going to share with you when it comes to dental surgeries and all of that, so that they can help with the medical assistance and all of that. Transportation, just some information around that through California Health and Wellness. We're going to share this information with you so you can use that. And with that, I try to go a little fast, so to catch all up, we would like to have some time to answer some questions. I'm gonna stop sharing and invite Andrea and our facilitators, Mary, and the rest of the group our moderators to bring the questions and answers to us.
Thank you, Dr. Amazon-Day, for this really wonderful, informative presentation. You have included quite a bit of information, and you've touched upon a lot of different topics. So the information, it's painted an overall picture of the different issues that we see in our county's children, and you've provided concrete ways that we can improve access to oral health care and improve our children's health. So we have a few questions. We have a couple of questions about how we can, or what are some examples of how poor oral health affects school performance?
Yes, yeah, definitely. And I would be happy to kind of give an overview, and then we can provide more resources later too. Really poor oral health, what happens is that when there is an active infection, inflammation in the body, right, it affects the whole body, right? So there's many studies that shows that a child that has an active decay and pain and infection is not able to focus, and also is not able to learn and thrive, right? And you know, if there's like when you look at the continuum of prevention to treatment, if you look at this disease could be prevented beforehand, before getting to that point, right? If there's needed a kind of extra treatment, or if the treatment gets delayed and needs you know, hospitalization or things like that, that kind of means missed days from school, right? So that's how like it kind of like creates the whole vicious cycle, as we talked about.
Thank you. We had a few questions about if the presentation is going to be recorded, if it's going to be shared, we'll be sharing documents. Yes to all of that. This is being recorded. We have put together a toolkit, and we will be sending out the toolkit, and it will have the presentation and various resources in it that we will share with everyone, and it'll come out in a few days. So yes, we will be. We had also a couple of questions about how soon after a fluoride varnish can a child eat or drink after having the treatment, the fluoride varnish?
Want me to answer, or Andrea, do you want to answer? You know, in most of the cases right after, as long as it's not hot. That's what most of the, right? We agree, Andrea? That's that most of them most recommend, most of the manufacturers.
We also had a question about, so the ADA is recommends the prescribing fluoride, and one of the participants' son's dentist stated that he only needs it to age 8, and she thought it should be to age 16. So we'd like your thoughts on that.
Yeah, from what I remember, and I will look into that, that's age 16. You know, of course, the 0 to 5 years old is more focused, right? But that's, I can double check on that too, but that's what I remember.
Okay, great. Amy Miles from the CHDP program had a comment about how their work group is revising the CHDP brochure, fluoride varnish brochure that we shared. And they learned that fluoride tablets and drops should not be given for 2 to 3 days after the fluoride varnish application. And that's per the manufacturer's instructions. So she's asking, should we also edit that varnish is best when applied 2 to 6 times per year, since Medi-Cal Dental will reimburse 3 times per year in addition to Medi-Cal reimbursing 3 times a year.
Yeah, I didn't know about the one about the distance between the varnish and tablets. So yeah, if the manufacturers has that, yes, definitely follow that. And as far as the 2 to 6 times per year, I think it's good to say that, because there's some, you know, there were some thoughts before, there's some concerns about the frequency and overlap between medical and dental, and then with some new research coming out actually through CDA, you know, it's I think it's good to kind of mention that, because it is more effective and it's applied and more frequent, and it's good to mention that. And thank you for bringing up that it's between those two. If they have a dental home, then that's good, and if they don't, then the medical home kind of taking some of that.
There was also a comment about applying the fluoride varnish to everyone, that adults rejoin teenage caries rates at age 60 if they grow up in a non-fluoridated community. Any thoughts on that?
I don't think I understood the question right. Andrea or anybody else, did you understand the question? You want to repeat that one more time, sorry.
Oh, sure. So the person is saying that they apply the fluoride varnish to everyone. He's saying that adults rejoin the teenage caries rates at age 60 if they grow up in a non-fluoridated community.
Oh, yes, yes, definitely. That's probably probably one of our dental colleagues on the call, because, you know, I would imagine that, you know, they can see that. Definitely. I mean, I'm always like, I don't understand it. Why we, you know, some of the practices, some of the dental practices don't do that for adults, because we do need, and they're like teenagers or high risk years, you know, then older adults are really high risk years, you know. So like you, all of you, if, you know, if when you go to your dentist, ask for it. Definitely.
Great. So there was a question about how does an organization learn if the fluoride varnish procedure is reimbursable and the process to follow for obtaining reimbursement?
That's a good question. And, you know, and I know we have our CHGP colleagues and as well as our managed care colleagues on the phone. We have had some conversations trying to figure that out as far as, you know, like if I'm a primary care provider in Ampla Health, for example, how do I know if you're fee for service, if you're IPA, if you're through managed care, you know, how does mechanism work? Sometimes there's not a simple rule for that. So I would say, you know, you have had to talk to your administration and kind of figure out which category you fall into. So if anybody else has anybody on the call has any other thoughts about that, please share. Oh, I see Alicia has raised her hand, so perhaps we can unmute her. I know Susie is gonna try to unmute you just in a second.
Can you hear me now?
Yes.
Okay, sorry. I'm sorry, but can you repeat the question, Mary? I thought you said if they have a managed care plan and they're under an IPA, they're not sure where to bill. Is that what you stated?
Well, the question is, how does an organization learn if the fluoride varnish procedure is reimbursable and the process to follow for obtaining reimbursement?
Yeah, so I know Emily's on the call as well, so Emily, correct me if I'm wrong, but it is reimbursable, and I think we gave the codes, which you know, Dr. over throughout the presentation. You would just need to identify. So as she stated, like if you're an IPA, if you're under an IPA, you would bill the IPA. It's part of the well child visit. And then if you are a fee-for-service provider under Anthem, you would bill Anthem directly. So I can put my information in the chat box. I'm not sure who asked that question, but if they're confused or have questions, they can go ahead and reach out to myself. Emily will put her information in the chat box as well, and then we can guide them. But there is a system called Availity where they can look up you know, if they should know if they're under an IPA or if they're fee for service, if it's an actual pediatrician doing the service, but I'm not sure who was asking that question.
Okay, thank you.
Mm-hmm.
We have another question. What's the best source to find out if your community's water is fluoridated?
So, you know, in this, there is a website through I think California Department of Health that tells you which communities, which cities are fluoridated. I personally think that can be improved to be a little more zip code oriented, but it gives you an overall idea where they are. But in these 3 counties, there's only like those 2 cities that we talked about that are fluoridated. And the rest, really, well water sometimes has a high concentration of fluoride. So, the California Water Boards. Thank you, Amy. Yes. Yeah, so that's, you know, so really kind of look into, you know, kind of like looking into that too. So that what is the concentration of fluoride in the well water?
Great. There was a couple of different questions around the process of doing an assessment and the fluoride varnish in the office, and are and the referral process, how important is it to do all of these in a practice and that you do it as a bundle? That you do them all at the same visit, basically, instead of kind of choosing one or the other.
I can answer, and then Andrea, please add. To me, I think it's really important because, really the effectiveness of all of these, and there's some studies that look into that if you just go and apply for advantage, it has some clinical efficacy, right? But it's really more effective when you're combining that together, right? Because you're really looking at all of the areas that this, the disease is happening, like the, dietary modification that need to happen, the changes in the kind of accessing to the care that it needs to happen. So to me, it's really important to do them as a bundle, right? Andrea, if you want to add to that.
I think it's just sort of natural to do it as a bundle, because if you're, you're looking at the child's teeth to see if there's any caries, and if, they need a referral to dental while you're in there, get some fluoride on their teeth, and then, also, get the referral in to get them the care they need, just, to either keep the teeth healthy or get them healthy again. So.
Great. Thank you. And thanks to Misha. She was the one that in our chat box, she put in the link to the water board, the California Water Board. There was also a comment advocating for application of the fluoride varnish in rural areas versus the system fluoridation. And I think that has to do in reference to that some areas have multiple wells in their water system. And so it might not be as practical to do that in a rural area, have them all fluoridated. I think that's what the person is referencing.
Yes, yeah. And again, that's why the first step in kind of like deciding if you want to order supplement is looking into the well water. And then if you can kind of measure the fluoride level of the well water and deciding from there. And I think the comment, I read the comment was from Mark Cave. It was very, very well taken that in the rural areas with a high risk, maybe it does make sense to kind of apply fluoride varnish more often if you're not sure about the fluoride content of the well water. Well taken, and I think, and in this at the same time, it's good to kind of explore that a little bit as well. Definitely. And I see Emily has her hands up, right, Susie?
Yeah, Emily from Anthem, I gave you permission to talk, so you can go ahead and unmute yourself.
Emily, you hear us?
Emily, are you able to unmute yourself? I don't think her mic is working.
Okay, so maybe we go with the next question while we figure that out.
Okay, so there's a question about, this is for Andre and the others. Does your clinic do fluoride varnish during sick visits if time allows? Or do you bring well kids in up to 4 times a year to receive varnish?
So we do not generally do fluoride varnish during sick visits. I know that is something that most of the managed care insurances would like us to try to do, to turn a sick visit into a well whenever possible. And we do try to do that, but most of our sick visits are 15 minutes long, and they're squeezed in between other appointments. So it's not always feasible, but we will definitely look back and see if a child is overdue for a well child appointment and try to turn that visit into a well child if possible. And then yes, we will do that. We do not bring them in 4 times a year, but younger kids come in, every couple months when they're infants, and then they come in when they're 2, when they're 2.5, 3, 3.5, 4, and then yearly after that. And so, for us, we just try to get that fluoride varnish on, you know, at least once a year, so that they're at least getting that, and hoping that they're establishing with a dental home and also getting it there, and just trying to, you know, to get that varnish on during the well child appointments when they're here. But yes, ideally, it would be wonderful to be able to do that every 3 months, even during a sick visit. There just isn't always time to keep the the workflow moving.
Okay, thank you, Andrea.
Billing wise, I wanted just to share that one of the slides that I didn't go in detail with had some billing codes that can be used when you are doing that in the sick child visits, or when it is not your main, main concern. So billing wise, it could work, but I think workflow wise, it's something to work through the clinic.
Right. Just a note, Emily put her contact information in the chat box. A couple of more questions around fluoride varnish. So any suggestions for an FQHC that are not applying fluoride varnish due to no reimbursement?
Yes, I would say, I mean, for all of us, right, as providers, we kind of like gotta do what we gotta do, right? We gotta kind of like incorporate that into what we do, because that's what matters, right? That's part of the overall health. Yet I understand the practicality of having more reimbursement really is an incentive for an FQHC, right, to move forward, right? So even though it's part of the bundle payment and fluoride varnish is included in that, but having incentives really, especially if you're like a local oral health program working with FQHCs, or a Department of Public Health working with FQHCs and want to do advocacy with the administration, there has been programs that we have put in place to really work either with managed care organizations or with other organizations to add some incentive, some add-on in some ways to kind of like make that happen. And there are, I know I'm seeing in the chat that there are some grants to do that, and that's great. Yeah, so we have to be innovative, right, to kind of like make that something that that organizations want to do and providers want to do. So it makes sense to kind of do some work around that. I hope it made sense. It was a quick version of saying that, yes, it takes some work, but it's doable.
Great. Emily made a comment as well. She said she just wanted to share that the fluoride varnish is part of the checklist with the initial health assessment and staying health assessment when our facility site reviewer nurse conducts medical review with primary care providers. And she's apologizing that her audio is not working. So thanks, Emily. There's a question about the prescription for fluoride tablets. Is it usually prescribed by the dentist or a primary care provider, or either or both?
Tablets, fluoride tablets.
Uh-huh.
That can be done again by both, or either. Medical, we are hoping that they don't both do that at the same time. But what I meant is that either one can do that. And in the case that dental access is less, it's great if the medical care providers do that.
Thank you. So a couple of questions more, and then I think we're going to run out of time, but we've had some questions about, tell us more about referring a child with special needs or a child with urgent dental needs.
Very good question. And again, I will ask other people to chime in too, but when there is an urgent dental need and if it's identified, it's really important to do the referral as soon as possible, right? I would say really kind of go beyond referral. Like if, in a primary care office, if you get the urgent care, like if it's an heart failure, you're not just going to tell them, here, go to the hospital and good luck, here's a name, right? The same with oral health, that can cause sepsis in a matter of days, right? And the child can be hospitalized, and it's really high risk. So first of all, yes, and what we need to do, the process is that's when you get your managed care organization involved, especially if they need hospital and general anesthesia, right? And then you can, Dentical has some dental case management phone line that you can contact them as well. Your local CHCP are the great resources to give you kind of like some referral. But I would really actually, when it's urgent care, I would go beyond referral. I'll do to an actual case management, right? Because again, you don't want to say, here you go and kind of good luck. Kind of really use the resources of a Dentical dental case management that they have, local CHDP, as well as your managed care organization to facilitate the process if hospitalization is necessary.
Great, thank you. So the last question here is kind of a double question, and it has to do with how much time does a fluoride varnish take for someone just learning this procedure versus someone who is experienced? And then how long does it take to do all the elements of oral health integration in a well-child visit?
Andrea, do you want to answer?
Sure. So it really doesn't take that much longer if you're new at it. We have the way it works for training here is our experienced nurses will train our new nurses how to do it, because we would love to all get formal training through CHDP, but those don't happen often. And with COVID, it's a little more difficult. But yeah, our experienced nurses do the training. And actually the nurse who did the varnish in my son's video has been here just about a year. And, so it's still more experience than someone brand new, but it is a pretty simple process to catch on to. You wipe the teeth with the gauze and paint and move on, and it goes pretty quickly.
Great, thank you. Okay, well, we've kind of ran out of time for questions. So if there's a burning question that you really want us to answer, please put it in the chat box or the Q&A, and we will get to it later if we have more time at the end. So thank you all for your wonderful questions, your participation.
Fantastic, thank you. So we're going to do a little bit of closing up here, like a little bit of discussion, we could answer questions during that too. So we're not all done, so a little more. So stay on. We have 10 more minutes, a little less than 10 minutes. So I'm just going to share my screen and kind of like finish it off with a few last slides. So thank you for standing by. So we just, wanted to really, with all of these questions, just kind of like include some discussions here. And I think if you wanted to kind of, raise your hand and unmute yourself, or if you wanted to put in the chat box, just really thinking about some of these, like what are some of the key take messages that you took from this webinar? Also, what would be some areas to follow up? What are some other needs for continuing webinars or resources on? What are some kind of burning areas that you wish you had more information on? What are some innovations? How can we be more innovative? And also, we are talking about the times of pandemics. What are some strategies to start implementing this in the times of the pandemic? So really want to kind of invite kind of the continuous of the Q&A that we had in the last few minutes that we have, to see if anybody has any more thoughts and any things that you want to share with us, either through the chat box or through kind of like raise your hand and kind of sharing that with us. I will start while these discussions come in, just talking about the innovations. And I remember at the beginning of the pandemic, in the first few months, that a lot of dental clinics were still closed. Some of our clinics, we're really thinking about, okay, we want to kind of incorporate, we know kids are home, everybody's home. We want to incorporate drive-through fluoride varnish applications. And I know Asian Health Services in Alameda County was one of the pioneers of doing that. And there were some other clinics that I think Maureen Community Clinic was the one that started to bring outdoors kind of like combining vaccination with oral health assessment and fluoride varnish application at the same time, and doing them outdoors. So that I have heard about a lot of really this kind of integration innovation that has happened organically. So there are ways to, again, kind of be more innovative and kind of start thinking about that, but it does take some effort. So I want to hear more from you guys. Any other thoughts? I hear in the chat, I see that there are a couple of requests to send a periodicity chart. Definitely. It would be great if, Andrea, you send it to us, and we will include that in our toolkit as well.
Yes.
Great, thank you. Any other thoughts? Any other questions? Any other thoughts around this? Any takeaway messages that you want to share with the rest of the group? I'm not seeing much in the chat, but again, anybody, if you want to raise your hands, and please feel free to do so. There is some very, and thank you so much, all of you, to be active through the chat box and sharing your experiences. And there are some of them that were shared just with the panelists, and I'm just going to share a little bit of that. There were some thoughts about how, again, just teenage and kind of adult time, maybe we shared that, are important times to also keep in mind. And definitely, like, it's really important to kind of like really look at it as a continuum as we talk with our communities. And just knowing that when we work with the families oral health affects the child oral health. So it's not actually that separate, right? Whatever you can do to share that, right? To kind of support the family's oral health. And I'm going to kind of go through them to see anywhere. Another area that was coming up is that kind of like the whole idea around how we could kind of like really kind of, when you are we can be innovative around dietary modification, right? And kind of like make sure that we are kind of like, let's say, and really incorporate that. Again, it takes time, but kind of like, how can we have sugar-free lollipops in our medical offices instead of, right? instead of the ones of sugar, or have other kind of things. So anything that kind of, incorporate, again, kind of like over time incorporates oral health into what we do.
My suggestion is doing a xylitol, a lollipop with xylitol.
Definitely.
Beneficial.
Definitely, yes. Anything else from all of you, Mary, Susie, Julissa, Angela, working at the local level, before we close up? Anything that you want to mention as far as from your perspective?
I just wanted to reiterate that I think it's important when we had a comment earlier about the clinic administrators playing a big role, getting the dental administrator, if it's a clinic that has both dental and medical, and you would, assume that they're talking to each other, and they could be right across the hall from each other, and sometimes they're not doing that. So yeah, bringing the clinic administrators to the table. And I was just curious, Andrea, did you, I'm not sure if you said it or not, but when you were talking about your piece and how you do integration, was that something implemented by your clinic administrator, or how did that come about?
It was in place when I started, but I think, I don't know. I should have probably looked into that a little bit more. I think that it was part of, it likely came both from CHDP and one of the GIPRA requirements from IHS. And one of the ways that, we have, NVIH has dental offices, but the Children's Center does not have dental. And so one of the ways that we can help with that particular measure is to do those fluoride varnishes here in our office. So, but I don't know where the request came first, unfortunately.
That's how the
That's
system
okay.
is
Thank
structured.
you.
Yeah. Fantastic. Well, gonna wrap it up. Just one last piece of advice from me, from my public health heart to your clinician public health hearts, is really kind of like when you're working with the communities, like understanding the barriers and lack of information a family is experiencing, and working with them from where they are, right? And knowing that it might not be their priority, but it still is hurting the children and the family, right? They may not have time for it. They may not know where to find the resources, but that's where we come in to help them, right? Double coaching with other diseases in your practices, just being an advocate for oral health, knowing that all of us are the basically preventive change advocates here, right? So being an agent for the change and kind of like for prevention, and just really looking at this disease from that perspective. Being innovative, working with partners, and staying informed around that. There's some new development around STF and other agents in oral health, and just like staying informed in that area as you would in other areas of health. And with that, I just wanted to mention that together we can, and really appreciate all of this work that we have done as a team here, amazing team that we have had. Really, the presentation is a result of all of that. Here are disclaimer that I have used some photos from some of the website and some of my colleagues' presentation, and I have let them know. And then there's some references on each page, but there's also some more. You will have a copy of this presentation, some resources for continuous education for providers, and oral health educational resources. And with that, I will give it to Susie and Mary.
Yes, so for everyone who is seeking CMEs and CEs, there will be an evaluation that you will have to fill out. So please complete that, and there will be a question about your license number. And so please have that ready when you fill out your evaluation. And there's actually 2 organizations giving out the credits. So if you're seeking CMEs, that will be through Enloe Medical Center. So you'll be getting an email from them, hopefully in a week or 2. And then you will be hearing from me at Butte County Public Health regarding CEs, and also in a week or 2. And if you have any questions, please contact me. And Mary, I'll give it to you.
All right. So just kind of ending and following up on a few things. There's going to be a link to a toolkit with the presentations, and the resources are going to be available in a few days, like was said, and they will be sent to you. So there's going to be a lot of different resources that you can use, a list of dental providers for the various counties, and forms and things like that coming your way. And a big thing, if you're interested in joining us on our workshops and to be a part of the local oral health program initiatives, please contact us. Our contact information will be on the last slide, and we would love to have you join us. Next slide. So again, I just want to thank everyone. Today we've learned a lot of great information, and we've learned that low utilization of children's dental care was already happening in our counties, and our Medi-Cal providers have been challenged, and that was before COVID-19 and the public health emergency. But we're seeing a consequence of the pandemic has been that we're seeing fewer children get in, and we're seeing disturbing decline in children's visits. When we looked at the data that Dr. Amanzadeh showed us today, it showed that California ranked 35th nationally in children's well-being before the pandemic. And as we've heard, our rural counties' children were even worse than the state's rates. So as a whole, due to different barriers and to different conditions that were eliminating access, our children are hurting. So COVID-19 has really compounded the inequities in our children accessing service and some of the child serving systems. So we're really hoping we can change that around. So As we've learned today that integrating oral health into our pediatric medical practice, it's very doable. And our hope is when that these collaborative efforts are focused on prevention and disease management, we'll see an increase in positive health outcomes for our children. So it's really doable. We're here to help. If you contact us, all 3 counties, the local oral health programs will help you. And I just want to give everyone a big thank you for taking the time, your time, to join us today. And I also want to thank that this amazing team, Susie, Jaleesa, Angela, Andrea, and Dr. Amanzada, for coming together and creating this wonderful presentation. And I feel Dr. Amanzada did an amazing job, just amazing. I really have been enriched by the whole process participating in this, and we hope to we have got momentum going, and we hope to move forward with this. So please contact us. Here's our information if you're interested in joining us. And I just want to have to everyone, stay healthy, stay safe, and thanks again for participating.
Thank you, everyone.